Appreciate it. We are going to get started, so let's go ahead and call the meeting to order. Then we can go ahead and do a roll call.
Ms. Pulowski.
Here.
Dr. Lazarchuk. Dr. Lazarchuk.
Here. I'm here.
Dr. Bradbury.
Here.
Mr. Ekman.
Here.
Ms. Laredo.
Here.
Dr. Payton.
Here.
Ms. Schafelt.
Here.
Dr. Sullivan.
Here.
Dr. Warner.
Present.
We have a quorum.
Great. Thank you very much. Okay, so I don't have any remarks this morning. I'm going to go ahead and we're going to get started. We do have, I think, a large member of the public joining us this morning. We're going to, for our first agenda item, I do need to go step forward to agenda item number 3 to public comment on items not on the agenda. So I will go ahead and hand it over to the moderator.
Thank you. I will go ahead and open up the Q&A panel. All right, so the question and answer panel is now available. If you would like to make a public comment, please type, "I would like to make a comment," and submit it to all panelists using the field in the lower right-hand corner of your screen. If you're not seeing this field, click on the question mark within a square at the bottom of your screen. We are displaying instructions for your reference. This is the moderator, and Madam Chair, I'm seeing no requests for public comment at this time. Would you like me to close the Q&A panel?
Yes, please. Thank you.
You're welcome. It's been closed.
Okay, so the next item on the agenda is to review and approve of July 22nd, 2020 committee meeting minutes. Any comments on this?
I move that they be approved.
I second.
Okay, so we have a motion and a second. Do we have any discussion?
This is Tara.
This meeting is being recorded.
I just want to remind the members, if you were not here at that meeting, you should probably abstain from voting. Also, can I please confirm who was the second on the motion?
It was Dr. Warner.
Thank you.
But both of, so Dr. Sullivan and Dr. Warner were present at that meeting. Okay, so do we have any discussion? Do I need to open this up to the public now for discussion?
Yes, moderator, if you can open up for public comment, that'd be
Sorry,
great.
I should have been specific to the moderator. Sorry.
No worries. This is the moderator. I will go ahead and open it up for public comment. And if anyone would like to make a public comment, please just type, "I would like to make a comment," and submit it to all panelists using the field in the lower right-hand corner of your screen. We'll give you a moment to access this feature. All right, this is the moderator, and Madam Chair, I see no requests for public comment. Would you like me to close the Q&A panel?
Yes, please.
All right, it's been closed.
And can we call for a vote on the minutes, please?
Dr. Lazarchuk.
Aye.
Dr. Bradbury. Dr. Ekman. I'm sorry, who just abstained? Hello? someone just abstained? Was it Dr. Bradbury? I think she's frozen. I think that was her abstaining. Mr. Ekman?
Aye.
Ms. Laredo?
Yes.
Dr. Payton?
Abstain.
Abstain for Dr. Payton. Ms. Sheffield?
Yes.
Dr. Sullivan?
Yes.
Dr. Warner?
Yes.
Thank you. Motion carries.
Thank you. Okay. So agenda item number 5, we are going to the discussion and potential recommendation on section 2032.1, Article 4, Division 20, Title 16 of California Code of Regulations regarding telemedicine and time to refill prescriptions. So I would like to discuss this a little bit. This is going to be a little bit different than we normally go over items in this, in the MDC. We normally will have the MDC discuss items and amongst ourselves and talk about subcommittee findings, and then we open it up to the public for discussion. This is such a very difficult topic, and we wanted to make sure that we open it up to our stakeholders and we hear this topic out. So our subcommittee, which is Dr. Sullivan and myself, have actually just read a lot of what has been discussed with the Veterinary Medical Board in advance, and we are listening to our stakeholders first. And we are asking that the MDC keep an open mind over this and really listen to our stakeholders' concerns, and we hear what they have to say and go over this. And we have not met to discuss this in advance. We will then use all of the information that has been gathered and then meet and talk about how we can move forward. The 2 bullet items here at the bottom have been what the public has, what we've found that the public's concerns are, which is the board's understanding that the VCPR is condition specific. Those are the things that they are looking for us to address. And the fact that the VCPR cannot be established via telemedicine. We're going to hear from a couple of groups that have been invited to share and give us a presentation. They will be able to share longer than the normal allotted times because they have been working with us and trying to prepare presentations. So they'll be giving us some of their information that they've gathered. And then we will open it up to the public as well. So I'm going to, at this time, ask, do we have them on at this time, Jessica?
Yes, we do, and they've been just promoted to panelists. So we have representatives from SPCA and CVMA as panelists.
Perfect. So we can go ahead and let them introduce themselves, and we can let them, I believe they're going to have the ability to share screen as well so that they can go over any presentation that they would like to do. So I'll let the moderator help them through this. Thank you.
So I think at this point, if we could have representatives from SPCA start with their presentation. I understand that you guys are not having any materials to share, so we'll leave the memo up on the screen for everybody to see. But if you don't mind starting the conversation and activating your video. Thank you.
All right, wonderful. Good morning. This is Brandy Kensel from the San Francisco SPCA, and I just wanted to make sure that we also have the 3 others available to speak at this time. I don't know if you can just like kind of pass a baton or to just speak up, but go ahead, the other people on the line as well.
This is Jessica Vogel saying I'm here.
Okay, wonderful. All right. Okay, good morning, and thank you so much to the committee for inviting us to speak here today. As I said, my name is Brandy Kensel, and I'm the General Counsel of the San Francisco SPCA, We operate 2 full-service veterinary hospitals in the Bay Area, and we service the general public and employ about 200 veterinary professionals. This presentation represents the position of the San Francisco SPCA, as well as the ASPCA, Best Friends Animal Society, the Humane Society of the United States, the Humane Society Veterinary Medical Association, and San Diego Humane Society. And today we are fortunate to be joined by some of the leading authorities in veterinary telemedicine. With me today is Bruce Wagman, a California licensed lawyer and one of the nation's preeminent animal law attorneys, as well as Dr. Shay Cox and Dr. Jessica Vogelsang, 2 California licensed veterinarians and acclaimed telehealth and technology advocates. In the next 15 minutes, which we were allotted, we have a pretty tight agenda here. Mr. Wagman will relay our legal recommendations for telemedicine and discuss their implications. Doctors Cox and Vogelsang will explain from the practitioner standpoint how telemedicine protects both consumers and animals. And I'll just pick back at the end of the presentation with a very brief closing thoughts for some suggested ways to continue to collaborate. And with that, I pass the baton to Mr. Wagman.
Thank you very much. Again, my name is Bruce Wagman, and I represent the San Francisco SPCA and the other groups mentioned by Ms. Kensel. As you know, the purpose of the Veterinary Medical Board is to protect consumers and animals by regulating licensees, promoting professional standards, and diligent enforcement of the California Veterinary Medicine Practice Act. And the purpose of the veterinarian client-patient relationship that we're talking about is to ensure that veterinarians know their animal patients well enough to diagnose and treat them. Before the waivers that we are discussing were in place, the VMB interpreted the VCPR as to require a new, hands-on, in-person visit for every time something different happened to a pet: a limp, diarrhea, a cough, a cut, a runny nose. But that interpretation is based on language in the regulation that a veterinarian must be able to, quote, initiate at least a general or preliminary diagnosis of the medical condition of the animals, unquote. The VMB had read that to mean that even for animals who a veterinarian was personally familiar with, that every time there was a new occurrence with the animal, the pet and the owner had to come into the office, and the veterinarian could not provide recommendations for treatment over the phone, even if she believed that was appropriate. Yet despite the identical language I've just read in regulations in states across the country, virtually every other state has interpreted the VCPR to allow for telehealth for new occurrences, and has given veterinarians the right to make the decision as to whether or not they needed to see the animal, or they could provide some general or preliminary diagnosis and recommended treatment over the phone. So the California waiver that we're talking about now is actually the same as the law has always been in other states. That is the way other states have always interpreted the VCPR requirements. And that is because other states interpret medical condition and general or preliminary diagnosis in a more reasonable and appropriate fashion. That is because the veterinarian already knows the general medical condition of a dog that she has already seen in person. This is a dog and a B. That is to protect consumers and animals, and that will be demonstrated by Dr. Cox. The reading is also contrary to the purpose of the VCPR, according to the interpretation of veterinary boards across the country, and that will be discussed by Dr. Vogelsang. So that brings us to the current issue and the request of these stakeholders to make the substantive changes triggered by the waivers permanent. As a legal and procedural matter, this can happen 2 ways, really. First, it could be by permanent waiver. That is, when the current waiver is about to expire at the end of the year, by the VMB simply stating that the waiver isn't extended and that there is no expiration date on that waiver. But that will really serve to continue to confuse practitioners who are currently confused about the situation, since a waiver sounds like it's an exception to a rule. It would be far more appropriate to simply acknowledge the VMB's revised interpretation of the VCPR medical condition requirement when it comes to telemedicine. That would not require new rulemaking. It would not require any change in the language of the VCPR regulation at issue. What is most important is clarity for California vets. and what they need is a crystal clear pronouncement from the board. Continuing to couch it as a waiver will not provide what the professionals need. What we propose as a practical matter is this. After the VCPR is established by an in-person visit, that it is up to the veterinarian to make the professional decision as to whether they need to put hands on again with a new occurrence that they get a call about, or whether they can do something over the phone. These are professionals, licensed and with the education credentials necessary to be proud California veterinarians. We should trust them. As a legal construct, it also fits directly with the VMB's mission of protecting consumers and animals, and really with the intent of the VCPR protection as interpreted by every other state. And as a professional practice, it makes far more sense for a veterinarian who actually knows the animal and can make that call, as opposed to a blanket edict that a veterinarian simply cannot offer advice over the phone. Additionally, in no way does this interpretation of the VCPR increase liability exposure for veterinarians. As we know, unfortunately, there are no shortage of claims made against veterinarians for alleged errors made while hands are on in the clinics. And this national interpretation of the VCPR is not going to change the likelihood of claims or impact it in terms of numbers in California. If it were, we would have seen that across the country and heard those concerns. We have not. We request that the VMB simply indicate to California veterinarians that the VCPR medical condition restriction be given a construction consistent with the VCPR rules around the country, so that California veterinarians can better serve their clients and their patients and do their job. In conjunction with the waiver of the VMB's restrictive interpretation of the specific medical condition requirement, the Department of Consumer Affairs also provided a 6-month extension to the 1-year limit on prescription refills. That is, while the current regulations require a visit to your veterinarian at least once a year in order to continue prescription medications, the DCA agreed to extend that 1 year to 18 months. We believe that waiver should also remain in place indefinitely to provide a bit more flexibility for clients who need to return to the veterinarian for a check-in and check-up before a prescription is refilled. Thank you again for your time, and I'll cede to Dr. Vogelsang, or Dr. Cox. I'm sorry, Dr. Cox.
This is Christy. I'm gonna interrupt really quickly. I just want to ask before you guys start, if you are able, if you can turn on your videos while you're speaking, that would be great. Thank you.
I think Dr. Cox is next, and I guess I avoided the video.
I'm still trying to figure all this out. I get it, Christy. It's nice to see your face and put a face to a name here. So let me start my video. Aha! Hey. Here I am. So thank you, Bruce, and thank you, board, very much for making this forum possible. I'm really excited to work together to address these issues around telehealth. As a quick introduction, I'm Shay Cox, and I own a 14-doctor hospice and palliative care practice here in the Bay Area. And our experience with telemedicine began in 2016, and since this time, we have successfully managed literally thousands of patients via telehealth without a single concern or issue. In fact, just the opposite. We've been able to greatly improve the delivery of care and, more importantly, the clinical outcomes. So while we do establish a VCPR for every single patient with a hands-on exam, we continue the majority of that medical management via telehealth for the duration of our relationship. So what brings me here today is, the board's interpretation of the Veterinary Practice Act limiting telehealth to those pre-existing conditions, which is not only concerning for us as veterinarians who rely on this modality, but really a huge disservice to clients and their pets. So, in trying to think of how to approach this with regards to examples, there are literally countless case studies and situations that we could share, but given the short amount of time, I wanted to focus on one recent example to illustrate. And, stressing that this is just a single example, but it's literally a microcosm for hundreds of examples that we're faced with every day. So the situation was a patient that I advised via telehealth last week. This pet was referred to us by an oncologist 6 months ago for hospice and pain management following the diagnosis of osteosarcoma, which is a bone tumor. So diagnosis, cancer. But last week, this patient so commonly developed diarrhea. And under the current VMB's reading of the VCPR, diarrhea would constitute a new medical condition. But because we do have these temporary waivers in place for us right now, we were able to visually triage that patient via telemedicine quickly, appropriately, and most importantly, successfully. And, here's what went down. The pet was still eating and drinking, normal attitude, and we could assess this over telehealth. So we elected to just monitor that patient for 24 hours with a bland diet to see if things would improve, just give it a little time. And it didn't. 24 hours went by. This patient actually got worse, but the patient, as far as diarrhea is concerned, but the patient himself was still having a normal attitude. So what we did at that point was to start a course of antibiotics and give sub-Q fluids for the next 2 days. And the pet continued to do well during this time. And the diarrhea eventually resolved on day 4 with our interventions. And, thinking about this and looking at just the opposite, if we were to revert back to that pre-existing condition clause or interpretation, what would have been the courses of action that owner could have taken? And, I think there's 3 feasible outcomes. 1, the owner would have to take her pet into the clinic with a bone tumor to get another hands-on exam because it's a new condition. And putting a pet with a bony tumor in a car not only has a chance to increase pain, but actually cause pain to happen if they had to brake or turn a corner. That is something that I've seen happen multiple times. And so it's a very high likelihood that could happen to this pet. The other option is nothing happens at all because the owner does not want to take her terminal pet into a hospital setting again. And so the diarrhea can continue to go unchecked and that pet ends up doing worse because we're not able to institute any treatment. Or the third common option is owner takes veterinary medicine into her own hands and she reads online that Imodium is great for stopping diarrhea in dogs, but doesn't realize that this also leads to severe cramping, severe discomfort, and worsening of quality of life by her good intentions without actually treating the underlying cause. So, in these situations, how are we protecting the consumer when we're not giving them veterinary guided options? If we return to the interpretation pre-waivers, we'd need to essentially perform an exam for every new symptom that arises. And not only is this not practical, I wholeheartedly believe this is a big disservice to both patient and client. And if we take that a step further, it's like, how do you draw the line between what constitutes a pre-existing condition and what doesn't? Using the example of diarrhea, which more often than not, we're never going to know the cause of it. How do you define and who interprets diarrhea or any symptom as a pre-existing condition? This is incredibly confusing for the veterinarian, something I deal with every single day. And it's impractical to have to lay my hands on a pet for every little new symptom that arises. It's, on that line, it's like the physical exam has this mystical status of being the only way to diagnose and treat a patient, which is just absolutely not the cause at all. Veterinarians, as Bruce said, should be allowed to use their judgment based on the situation and the circumstance within the confines of an established VCPR. And if we can't do that, if we go back to these pre-existing conditions, I feel we're going to be doing a lot more harm than good. And, my plea, and the plea of so many, is to have the board trust doctors to make the right decisions as to when telemedicine is appropriate and when it isn't, again, within the confines of the VCPR. Because if my degree and experience and training and clinical assessment does not entitle me to make these basic and fundamental care decisions, then I'm concerned our profession is breaking, and that is not a place I want to be in. So thank you for listening to that and for hearing this side from the veterinarians, and I will now pass on additional comments to Dr. Vogelsang. Thank you.
Thank you so much, Shay. All right, good. I got my camera going. So thank you again to the MDC for this opportunity to speak today. And also, I want to thank our colleagues from the animal welfare community for giving Dr. Cox and I this opportunity to participate in this discussion, because this affects everyone with a stake in the future of animal care. So I'm here today to give you a little bit of context about veterinary telehealth in all of North America and encourage you to take today's requested steps to ensure California doesn't fall behind the rest of the country. So as we said, my name is Jessica Vogelsang. I've practiced veterinary medicine in San Diego for the entirety of my 18-year career in general practice, emergency medicine, and hospice care. I first got involved in the telehealth space in 2009. I've also served as medical director for an international teleadvice service, and I've had the privilege of speaking with animal owners around the world about both their successes and their failures in their efforts to access veterinary care. We are at a critical juncture right now in the history of this profession. Now, this was precipitated by COVID, but this is something that has been in the works for a very long time. We can no longer afford to ignore the importance of the online space in the way that patients access care. Clients that we can't or won't help don't go to the ER all the time, right? Most of the time they go online into this sea of terrible misinformation. And every day I see and hear the results of those dangerous conversations that they're having. They dose their cats with baby Tylenol, their dogs with Aleve. They assemble do-it-yourself kits from Home Depot to treat life-threatening bloat with rubber tubing from aisle 12. I recently even saw an article online that's making the rounds about how to euthanize your cat at home using household tools. It is, as you can imagine, absolutely horrific. And the reason that this anonymous, faceless stranger gave for giving this terrible advice is, we know your vet doesn't have time for you right now. As a profession, we've allowed this fear of what might happen in the hands of veterinarians to blind us to the reality of what is happening right now when lay people take over our roles. Every day that we refuse to look to the future digs a bigger hole as outside parties step into this sphere of influence that we have willingly abdicated. Restricting telemedicine doesn't protect consumers from bad veterinarians. It exposes them further to the dangers of non-DVMs. A permanent waiver to this new condition clause of the VCPR is a common sense approach that will allow the veterinarians in our great state to engage with telemedicine in a safe manner, consistent with the way it is already being used in the rest of the country. As a founding board member of the newly established Veterinary Virtual Care Association, I have the privilege of seeing how telemedicine is being used worldwide to improve patient outcomes and elevate the role of veterinarians in the virtual space. While much of these historic conversations surrounding telemedicine are based in conjecture and fear, I truly, truly hope that you'll take to heart the evidence that we are presenting today that illustrates how telemedicine can and is being practiced in a pragmatic, safe, and effective manner. The critical point to remember is that the standard of care for telemedicine is no different than it is for in-person medicine. If a veterinarian is unable to gather enough data to reach a diagnosis without a physical exam, then they can't gather a diagnosis. The patient must be seen in person. That is our mandate. It is well accepted that telemedicine has limited use cases and is not appropriate in all situations, in fact, in many situations, but is invaluable for the right patients, such as the ones that Dr. Cox spoke about last. I also serve on the regulatory advisory board of the VVCA, and I'd like to share what we've learned over the last 6 months. Since the onset of COVID, 15 states and counting have made telemedicine more accessible to veterinarians with the allowance for remote VCPR. In Ontario, allowing telemedicine to establish a VCPR has been legal for 3 years. The fears that people mention have not come to pass. The sky has not fallen. Ontario has registered literally zero complaints in those 3 years with regards to telemedicine. Far from driving clients away from their regular vets, it brings them closer by allowing a more convenient means to access care and enhancing that bond of trust that is so essential for patient outcomes. I want to reiterate what Bruce stated earlier. To our knowledge, California is the only state with a condition-specific mandate to the VCPR. If this waiver expires, this means California will revert to being the most regressive state in the union with regards to veterinary telemedicine, dead last in the March for Progress. We have 15 states that are leading the way, 34 that are playing it a little bit more safe, and then behind all of them could be us. The number one reason that I hear from California practitioners for choosing not to utilize telemedicine is confusion. Not about the medicine, but about our policy. They're confident that they can select appropriate use cases. We are confident in our judgment and our discretion. What we lack is clarity from the board about what we can and cannot do with this information, confusion about whether what we're doing right now will be legal in a few months, and not enough time to figure this out for ourselves. I urge you, do not squander this chance to be real leaders at this critical time. As the home of the #1 veterinary school in the country, a proud graduate of UC Davis, there is no reason that California should be one step behind the rest of the world in allowing this basic communication tool to be used to its fullest extent. If we don't take this step now, we'll continue to fall behind the rest of the world as the consumers we're charged to serve continue to rely on Dr. Google in our absence. Thanks again for giving us this time, and I look forward to what we can accomplish as a profession moving forward. Thank you for opening this dialogue, and we are always open to talking to you about our experiences and what's going on in the rest of the world. So thank you again. And with that, I would like to pass this back to Bruce Wegman for our final thoughts.
So thank you so much, Dr. Vogelsang. I just want to quickly close. This is again Brandy from the San Francisco SPCA. I just want to close with 2 suggested ways for our kind of continued collaboration on this pretty dynamic topic. So number 1, as we've heard from the presenters, there is a lot of confusion among veterinarians and consumers related to the practice of telemedicine in California. So we see a real opportunity for the V&B to provide this additional guidance to both veterinarians and consumers. And our organizations would love the opportunity to work with the V&B to kind of clarify existing misconceptions and get the word out among our constituents about any changes that may or may not be made in the future. Number 2, we believe that the recommendations that we are making today are conservative, they're productive, they're sensible at this time, and they represent already established common ground based on the DCA waivers. However, since telemedicine trends and technologies, they're rapidly evolving. Ideally, this is just the first of many conversations, and we think it would be prudent if the MDC and V&B are open to it to connect regularly again on this topic, perhaps annually, and continually evaluate advancements in digital health. And with that, just to reiterate what the speakers before me said, please consider us all a resource, the San Francisco SPCA, the ASPCA, Best Friends, HSUS, HSVMA, San Diego Humane, the speakers here today. We want to definitely be a resource available to the MDC and the entire V&B on this topic. Thanks so much.
Thank you all very much for sharing, and we very much appreciate all of the information that you have given us. And I want to go ahead, I do want to remind everybody that there is, if you have questions during any of the presentations or at any time during the conversation, there is in the bottom right-hand side of your screen, there's a little hand. You can raise your hand so that we can answer your questions. You can ask a hand. It says raise hand. So if you see that, we can help you during this, so we can ask any questions of our presenters. So I will go ahead and give anybody a minute, since if they had any questions, they can ask anybody any questions. And then I can go ahead and we can bring on our next presenter, which I believe is the California Veterinary Medical Association, if they are ready to present.
This is the moderator, and I'm the California Veterinary Medical Association. They are logged in. They have a camera. They're currently muted. but they are a panelist.
Nope, they're unmuted now.
Okay, I will start again. Can you hear us now? Okay, great. This is Val Fenstermaker, and I'm in our conference room with Dan Baxter and Dr. Grant Miller on our staff, so they are also available for questions as the discussion goes along. I did check in with the AVMA before making this statement, and their policies are consistent with the CVMA. And we both support the veterinarian client-patient relationship that includes an in-person examination of the animal patient, which encompasses each condition being treated. The Practice Act allows for this to be accomplished in both small and large animal medicine, which I'm not sure everybody always realizes. It says the veterinarian must be personally acquainted by virtue of an examination or by medically appropriate and timely visits to the premises, and this allows for leeway in herd health. After that, telemedicine may be used after the BCPR is established. It's really important to note that veterinary medicine it's more than just a visual profession. Smell and touch are integral to making the correct diagnosis, and that cannot be done virtually. That is the core of being a veterinarian. It's what every veterinarian learns when they're in vet school, and this makes it very different from human medicine, where telemedicine is more commonly used. We also have concerns about the internet, to be frank. It's not always a lovely place, and we're not sure that the enforcement authority of the board will really protect the consumer when it comes to telemedicine, and whether animal owners will actually be talking to licensed California veterinarians or actually to a veterinarian at all. How are they going to be protected, and how will animals be protected in this environment? We are exploring the use of telemedicine. We know that there is a place for it, but we believe that how it stands right now is appropriate. And we are talking to our members in upcoming meetings, and we'll be gathering information on how it has worked during COVID. So that's just our brief comments, but as I say, we're available for questions.
Thank you very much. I appreciate your comments. Do we have any questions? Anybody have any questions? Moderator, I don't know if you want to open this up to any questions so far.
Thank you, Madam Chair. I will go ahead and open up the Q&A panel in just a moment. This is the moderator. I apologize. I changed my view, and that option's disappeared for me, so I am finding it. So please forgive me for this pause.
We can even have any questions of the MDC of our presenters so far.
Ms. Pulaski, I see that Dr. Bradbury has her hand up.
I was specifically looking and I cannot see it. But go ahead. I apologize, Dr. Bradbury, because I was looking for everybody's hand. Go right ahead. I apologize.
That's okay. I usually just interrupt everybody, so I'm trying to be polite. Sorry. Can you hear me?
My hairs.
Can you guys hear me? Yeah? Okay. I had a question for Val, and I guess my question is one of the main concerns about protecting consumers from the internet and, with telemedicine, obviously using the internet. I guess my question is, how are we protecting them when they're already using the internet and without us allowing California veterinarians who are licensed and who would then be covered by the Practice Act the consumers protected by the standard of care that we determine? How are we protecting consumers if we prevent California veterinarians from being able to do this while they're still going to be able to get it from wherever they'd like otherwise? Instead, they might be getting it from somebody more trusted and who is being regulated. So I'm unclear on how the concern of the internet is, is going to be addressed by us not moving forward with trying to allow for telehealth.
So I guess I'm not clear. Opening up telemedicine in California is, to me, the Veterinary Medical Board is responsible for making sure that outside influences from telemedicine, from unregistered, from unlicensed veterinarians, or from anybody on the internet should be enforced by the Veterinary Medical Board. So I'm not seeing how that would make a difference if California veterinarians were somehow allowed to practice telemedicine. It's illegal to practice veterinary medicine in California without a license, period. And that should be enforced by the board, no matter what telemedicine does.
Yeah, I definitely, I mean, obviously that is the case. However, we have to have people reporting that to us. I think the way that it would benefit the consumers for us to have some allowance for it is that instead of turning to random people who are breaking the law, who we may have no knowledge of, going to a California veterinarian who, if they aren't standards and are trying to diagnose and treat animals that really they should be telling them, hey, they're vomiting, we really need to do some tests, you need to come in, versus, oh, okay, they have diarrhea, like the example that was given. By having California veterinarians being the one that the clients are turning to legally, then we suddenly have some regulatory authority over them, versus when what's happening right now, where they're going probably to the website. So I'm not sure. Does that make sense?
Hi, Dr. Bradbury. This is Dr. Miller from the CVMA, and we do believe we're understanding the gist of what you're saying, but would like to circle back to the existing law in California, which does allow for a very detailed use of telemedicine currently. The challenge with opening it up to the diagnosis of a new condition or a condition or a situation in which you haven't physically examined the patient means that somebody in Canada or in any place in the world, in India, could be providing telemedicine services here. And the challenge with that is that if it's legal to practice telemedicine in the state of California, there's nothing to say that those people can't do it. Whereas right now, it's illegal to be doing that if you're not a licensed veterinarian in the state of California. And if you're a licensed veterinarian in the state of California, you have to go by what our Practice Act says, which says that you have to physically examine an animal patient. And of course, the safety protection in that is that we're utilizing our five senses as we were trained to do in veterinary school to gather a sufficient amount of information about the animal patient to make a diagnosis. With, for instance, our progressive laws on the judicious use of antibiotics, it would be a challenge to use telemedicine and also judiciously use antibiotics, since you are much further away from a confirmed diagnosis with telemedicine than you would be otherwise if you're examining the animal patient. So I don't think anybody involved, I don't think anybody would argue that that there is a benefit to having a veterinarian examine a patient in person. That's what we've all been trained to do. And so we've incorporated telemedicine into our Practice Act in the state to be able to accommodate that to the extent that it can. And that's currently, what many veterinarians are using to manage cases. It's, for like the example you said of a chronic diarrhea case, if they've seen that in person, they have the ability to continue to manage that by telemedicine once they've made a preliminary diagnosis, but without, by virtual physical exam. But if they haven't done that first, then there can be some real challenges with that on misdiagnosing the patient.
Is it okay if I keep going back and
Let's, let me go to, first we have Dr. Cox and then Bruce Wagman. So let's go ahead and start there.
I just wanted to ask Dr. Miller a clarifying question with regards, I think this conversation around telehealth is obviously a much bigger conversation to have, and to bring it back to what we're talking about here today is the waivers for pre-existing conditions. Is it my understanding that the CVMA is in favor of seeing a pet for every single new symptom that develops because it could be a new pre-existing condition? And how do you interpret that? How would you explain that to veterinarians? In the case of my osteosarcoma patient, diagnosis cancer, but developed diarrhea, how am I to help that patient unless I see that patient in person if we revert back to those rules? So I want to understand your perspective on that, what your thoughts are around that, and where you're falling on that line.
CVMA, did you want to respond, or are you going to?
Thank you, Dr. Cox, for that. I appreciate your comments, and I think you're very well spoken on some of the hurdles that you encounter. I would just like to reiterate that the CVMA supports the current law in the state of California. So this is less about our policy and our interpretation and more about what our law says here in California. And our law reflects what we do every day. It reflects what we've been trained to do in veterinary school. So that's our current position on it. And, I appreciate that you're here and that you're opening up this conversation. I don't want to, work against you in what you're talking about. I would just like to make it clear, as Valerie had mentioned before, that we are in support of the current law in California.
Correct. But the current law doesn't stipulate a pre-existing condition per se to interpretation. There's too much gray area around that, and I think that speaks to Jessica's point that as veterinarians we are confused. How do we break down that confusion barrier when you see all the time in practice that you have a patient, you've established a VCPR, they call because their pet has vomiting or it ate a 5-ounce piece of chocolate or whatever. You can still provide advice without touching that patient again. So what I'm hearing, and maybe I'm hearing this incorrectly, currently the VMB is saying every new symptom, every new condition, you need to establish a new VCPR. The CVMA is saying we're following the law, the line of the law, which I'm all in favor for, but there's a bit of incongruity or misconnection to me. And I think Dr. Vogelsang wants to actually ask a question. She's like, how do I raise my hand? But I think she would be able to speak to the same question because I think we're both confused on this. If you wouldn't mind passing this to Jessica, please.
I actually am going to pass it to her in just a moment. I actually have Susan who wants to ask a question as well. So hold on just a moment. Let me get Susan in here as well. Susan, go ahead.
Hi, good morning. Susan Riggs with the ASPCA. Again, thank you so much for taking the time for this really important discussion today. And I just wanted to maybe reflect back on some of what I'm hearing, and particularly some of the questions that have been raised by the VMA. I think the first thing is in regards to using all 5 senses, and I think there's an assumption on the part of the VMA that this is something that is being imposed on all veterinarians to to do automatically. But I think what we're saying is this is a discretion. This is intended to be something discretionary for veterinarians and their professional judgment to make a determination of whether, based upon their experience and having seen the animal before, they need to see it again in person, or if there are alternatives based upon what they're seeing and hearing through telemedicine. If not, then they use their professional judgment to ask for the animal to come in so that they can use those 5 senses. So I think that's the first thing. And then the second thing that I want to just observe is, in regards to the establishing the VCPR, I think there's an assumption here that it seems to me that the VMA is making that the animal would never have been seen. And, if what we're asking for is for these existing temporary waivers to become permanent, there still would be the establishment of a VCPR in person. And so to assume that someone out of state or someone that is not licensed in the state would be able to automatically establish that over telemedicine is erroneous, number one. But I think, two, the point that has been made, I think a couple times, is that the existing interpretation of the regulations really are serving as a barrier that is pushing many folks to utilize the internet in a really negative way, in ways that can be detrimental both to the consumer and to the animal. And so, I think this is just, it's a realistic reaction to how consumers are reacting in the marketplace, and an acknowledgement that if there are barriers placed on veterinary medicine irrationally, that the reaction of consumers are to go online and to perhaps practice medicine themselves. And we don't want that. That's not good for the consumer, and that's not good for the animals. And so, this seems like a very reasonable approach to, number one, allowing veterinarians to practice their professional judgment, and number two, to avoid the negative consequences of what is already happening in the marketplace, which is that consumers are trying to practice medicine themselves because barriers have been put in place. So I, again, appreciate the time and your consideration of this.
Thank you. Mr. Wagman, I put you off. Do you want to go ahead and speak? I've gone all the way around. I apologize.
Oh, yeah, no problem at all. Thank you very much for the time. And I think Ms. Riggs said a lot of what I said, what I was going to say, but just as a bullet point, what we're suggesting, and Dr. Cox said the same thing, is that there would be a VCPR established. The veterinarian giving the telehealth would be a veterinarian who had put hands on the animal. So the suggestions of CVMA that somebody from Canada or India could be doing it, that's not even a question here. That's completely inappropriate to what we're talking about and what we've suggested. It simply does not exist. With respect to unsolicited internet, again, same thing. You'd have to be talking to a vet who had seen it. In fact, what we are trying to do is prevent the kind of horrific problems that Dr. Vogelsang talked about, Home Depot bloat kits and kitchen utensils to kill animals. We're trying to prevent that by having a VCPR established and having that veterinarian. So I'm not sure why the CVMA thinks that somebody from India could play in this space at all. They would be breaking the law. It's California veterans who would be supplying California telehealth. And finally, the current law that Dr. Miller refers does not say what CVMA says it says. And that is proven by the fact that 49 other states read it a different way. It's some language in a law that everybody knows can be interpreted different ways. And that's what the other 49 states have. This medical condition notion does not say the specific medical condition. That is the dog with osteosarcoma who has developed diarrhea. The medical condition of that dog is, for example, 10-year-old dog with osteosarcoma 4 months in who is suffering in pain and is on the following medications. That is something Dr. Cox would know all about. That's the medical condition that needs to be read into the regulation. And the new medical condition of diarrhea, again, is something that California veterinarians are worried about because of the current interpretation. But I want to stress it is just an interpretation. It is not in the language of the regulation. Thank you very much for the time.
Thank you. So I believe we have Dr. Cox, you wanted to speak again? Oh, wait, and Tara Welch.
Jessica.
Because I have Tara has her hand waiting patiently.
Yeah, I was passing the baton to Jessica.
I have Jessica Vogel saying, and I have Tara. I'm trying to read all of the participants. I apologize. I'm looking at hands raised. I know. I apologize, Dr. Vogel saying.
No, what a fantastic dialogue, and again, thank you so much for allowing us to have it, because it is so important to clarify some of these misconceptions. And I think, again, everyone's done a really good job of clarifying, our fears versus what actually happens. We know now from a decade of consumer behavior that they want to engage with us online. So again, to the point that Susan was making and Bruce was making, this is how people seek care. They just do, regardless of whether or not we allow veterinarians to do it. This is what they're looking for. And so again, creating these unnecessary barriers instead of trusting our judgment, it's just one more way that we're making it more difficult for the consumers to be protected. And to Bruce's point, we're not protecting them against other vets in India or Canada. Like that has not happened. Even if it could theoretically, like we've been seeing what's happening now in other states and in Canada, and that's not how it's been working. That is not, other veterinarians do not have an interest in swooping into California and taking over our territory. That's not the problem. So I think, I'm just asking people to be a little realistic about what consumers want. And what they want is access to their trusted veterinarian. We know this from the human side and from what we're seeing in the other states. They want to access their California veterinarian that they have already met. We know that relationship, that VCPR has value. To Shay's point, there's not a very specific delineation between presenting complaints and conditions. You can have a presenting complaint that's related to a condition that you've already diagnosed or not, but it is that relationship that you've already established that helps you make that determination. And so I just wanted to reiterate again, that a lot of these fears just simply haven't come to pass. And so one last thing, on the Veterinary Virtual Care Association, we have AVMA as one of our members. I sit with Gail Golab on the advisory committee, and we all sort of stand behind the AVMA's interpretation of the Model Practice Act. But again, there is nothing in that Model Practice Act that specifically states that there is a condition-specific aspect to the VCPR, and I have not heard anything from them to that specific point that we're arguing today. So I just wanted to clarify that. Thanks.
Thank you. Okay, sorry, Tara, go ahead.
I just want to make a couple clarifications. So first off, our regulation in California does not track the AVMA model law, and our regulation under California Code of Regulations, Title 16, Section 2032.1, does require condition-specific VCPR. So it's not just an interpretation. I think that's really important for everyone to recognize. It's 2032.1, subsection B3, requiring to establish a VCPR, the veterinarian has assumed responsibility for making medical judgments regarding the health of the animal and has communicated with the client a course of treatment appropriate to the circumstance. That language is not in the AVMA model law. It is in California's law. So that's the language. We're not interpreting it differently from what the AVMA is doing because the AVMA model law doesn't contain that language. But also, with respect to how other states are interpreting the law, I don't think they're using California regulations. So however they're interpreting their own law to perform telemedicine without a condition-specific requirement, that's other states. My point there is just that it's not a matter of interpreting our law differently. It would be a matter of, as we discussed at the May meeting, we would have to change the regulation itself. And as far as making the DCA director's waivers permanent, we as the board do not have authority to make the director's waivers permanent. We would again have to change the regulation to accomplish what the ask is here. That's all I wanted to clarify.
Thank you. Dr. Sullivan?
I better unmute myself first. Just a couple of comments. The first is the anecdotal stories go both ways. A couple of weeks ago, I had a client that called me that I have a BCPR with. And under our payment policy, after a client has made 2 visits to the clinic within a year, there's not another office call charge. So there was no reason that I would financially ask her to come in. And she wanted some antibiotics because her dog had a urinary tract infection, totally unrelated to previous issues. So I talked to her, and the symptoms, yes, were consistent with urinary tract infection, but I did not feel comfortable prescribing an antibiotic for that. The patient came in, and lo and behold, the reason that the dog had urinary tract symptoms was that it had, and it was a female, had a bone cancer in the pelvic region that was putting pressure on the urethra, and she was straining to urinate, and only a small amount of urine was coming out at a time, and there was blood with it. So there are anecdotal stories on both sides. We can go on and on and on about the dog that was subtly listless for 4 or 5 hours, and the client decided to come in with it with the patient, and it had a bleeding episode of a bleeding spleen, and yet the symptoms to the owner were totally unrelated to the actual course of the disease. So, and finally, I would like to go to the American Telehealth Association's guidelines for pediatrics, which says that infants under 2 years of age need an hands-on examination to establish a VCPR. And I think that our patients are very similar to that. I think that the comments about once you establish a VCPR, that then you can do telehealth or telemedicine, I should say, bothers me a lot, because in an example that was given, I believe, by the attorney, that a health exam on later has symptoms of a skin issue or sneezing or whatever the symptoms might be, why shouldn't we be able to medicate that animal? Well, if those skin symptoms happen to be a ringworm, you are, and the only way I know of differentiating ringworm and mange and skin allergies or even dry skin is by physically looking at them and testing it. You can risk exposing the whole family to ringworm, and this has happened. And so I think that if we're going to focus on the VCPR and the umbrella that it gives us, I think that we need to then focus on what that primary diagnosis is. I am somewhat relieved that you're saying that the veterinarian has to have the VCPR, because there are a lot of companies out there that are seeking business in California, and I've been consulted with them that want to do this work internationally, and there are companies out there that are doing it now without establishing a VCPR in person. So I am relieved at that. But saying that VCPR is good for 6 months or 9 months, or a health exam alleviates having to have an in-person exam for a condition that's 4 months out, is, in my estimation is a lowering of the standard of practice in this state. Thank you.
Thank you. Dr. Payton?
Yeah, so I just wanted to ask a little different view, because one of the arguments that I'm hearing is that by having where we can discuss with clients after a VCPR is established, having the no, it doesn't matter as far as the condition, is that the argument is that clients will have increased access for talking to us and getting advice. So one, I think the argument that was made in that regard, that people won't go on the internet and look for advice, I'm not sure that, I think people will do that regardless. They do that now. And I think one of the biggest barriers, whether it's in person or telemedicine, is paying for services. So I think with that barrier in place, people will always look for advice on the internet. But saying that, the question that I propose, I would love to hear from the groups, especially that have a lot of experience with the telemedicine, is do you have any data? Because if we're saying that it increases access for people to get advice once your VCPR is established, do you have any data that's been gathered to show that there is better access to people? Because I just would really be curious if that's true, because it still takes time for practitioners to set appointments, whether it's in person or via using telemedicine platform. So I just propose that question: if if you're saying there's better access for people, that they can get appointments and be seen with less hassle, is there any data that's out there right now?
I actually, on that same line, I have a question related to that, because it is a data question. There was a question, or there was something that said that veterinarian doesn't have time for you right now. And that was the general consensus of, you're saying that's why the person was putting out the information on the how to euthanize your cat. And so it was, I would like, do you have any data of how telemedicine would increase the amount of time that a veterinarian would be able to give to a client? How would that change anything? So I would like to know the data that you have on that, since you're bringing up that data.
Sure, and I can address that, since those were points that I had mentioned. So the problem right now is that we are still in the data gathering phase, right? This is something that is new. So the only data for sure that we have right now is how many people have actually shown harm from telemedicine, and we don't have any examples of that right now. The Veterinary Virtual Care Association is in the process of doing a multinational survey right now, and so we expect to have that data soon, so we can provide you with those points. And unfortunately, right now, what we do have is anecdotal. When it comes to access to care, all I can address is the perception, and that's why I don't know who this person is, so I don't know why they said that, but I know that is the perception among consumers. And in many places, we do have increased wait times to get into the veterinarian because of COVID and the use of curbside. And so what we have been seeing with our practitioners, again, few of them in California because they're scared to do it, but I'll give you an example of Aaron Smiley in Indiana, who's done about 3,000 telemedicine visits, and telemedicine allows you to scale. And so what you do is sort out your appropriate and inappropriate use cases. And again, Dr. Sullivan, I think, was talking about what would be an inappropriate use case. All right. Inappropriate elimination is not an appropriate use case for telemedicine. So that automatically gets routed to needs to come in. And so you're taking your appropriate use cases and basically screening them using telemedicine. There are so many fail safes along the way here for that veterinarian to say, nope, that one needs to come in. That could be ringworm. I'm worried it's zoonotic. They come in. And then there is that percentage, and it's not insignificant, of things that you can either put off towards later. You can have it come in for a technician visit, which is 15 minutes versus a 45-minute, hour-long time in the clinic. And because of that, we are seeing people scale. And so Dr. Smiley will tell you that he can see or talk to, because he uses texting for a lot of his visits, 15. He can address 15 concerns in an hour using telemedicine versus what it would take when they come in. So in that regard, we do expect to see the outcomes being increased access to care with those people that are using it because of the ability to scale, to better utilize your staff, to do a lot of that cumbersome communication things outside of the four walls of the clinic. But again, we are not asking anybody to go outside of their comfort zone, to diagnose something. If you feel like you got to smell it, make them come in and you can smell it. Like we are not asking anybody to change those things. And again, this is about trusting the licensees of the state of California to have the knowledge and the discretion to be able to differentiate that. And I guess this is just a matter at this point of whether or not you believe that we do.
Anybody have any other comments or questions? I know we have some questions from the public. What we're going to do is we're going to actually take a short break and then come back and address any of the public. We're going to handle the public comments. So I'd like to finish with the MDC comments. I think I've got everybody else's comments here from the MDC and our panelists. Dr. Bradbury.
After the public, we'll talk again about this, right? We'll like have a kind of final discussion. I've just not been part of this, so.
Yes. Correct. Yes. Will 10 minutes give everybody enough time to break and be right back? Okay, so we'll be back at 10:25. Great, thank you. Don't we love when our animals have to get in on the picture, Leah?
I know, they've been good today.
I know. Dr. Warner's dog's been with me. It's like, wait, I like it. I like being at home.
Oh, she's bad. I was going to put her in a Halloween costume for you, Christy, but, you know, they stayed today.
Okay, sorry everybody.
This meeting is being recorded.
I knew that was coming. So had a work thing. Okay, let's get started back. First, if I could have everybody reset, and if you had previously raised your hand to make a comment, let's have you take your hand down so that I know and I can make sure that we all are on the same page. And I see a couple of you still have your hands up. That way I know we're going to start fresh. So Dr. Cox and Mr. Wagman, I still have your hands up on our panelists. Okay.
I can't seem to get my hand down, but it's down, I promise.
Yeah, that happens. I know. Sometimes some of them get stuck up, but that's okay. So you'll just have to let me know if you have a question in the future. So, okay. So moderator, if we can open it up, I see that we have public comment. So if we can open it up to public comment, and then we will go back to our MDC so that we can just open it up for discussion.
This is the moderator. Thank you, Madam Chair. Yes, the Q&A panel is available, so if anyone would like to make a public comment, please type, "I would like to make a comment" in the field in the lower right-hand corner of your screen and submit it to all panelists. We do at this time have one member of the public that would like to make a comment, Nancy Ehrlich. Nancy, I'll let you know when you've been unmuted. And Nancy, you've been unmuted.
Okay, thank you. I just have a short comment that I've been in this business for a long time, over 40 years, and we've been giving advice over the telephone all this time to our clients with whom we have established VCPRs. So I don't quite understand that if we have a screen where we can actually see the patient, that's a downside. That seems to make it even better, that we can give better advice over the telephone as long as we have a VCPR. So I think this issue is really overblown, and that we advantage our clients and our patients by being able to see them over the internet if it's appropriate. And of course, it's up to the veterinarian to decide if it's appropriate. And I've heard other people make these comments, but I just want to emphasize that we are going through a pandemic right now. And I've been told I can't get my dog's teeth cleaned until January or February. So we do need to do something to make veterinary medicine more accessible. Thank you.
All right. Thank you, Nancy. And this is the moderator. I do not see any further requests for public comment. So would you like me to close the Q&A panel?
Yes, thank you.
You're welcome. It's been closed.
Okay, do we have any more comments from? Yes, we do. Wait, it told me we did, and then nobody's raising their hand. Okay. Oh, there you go, Dr. Bradbury. I'm like, I know I saw your hand waving in the air earlier. Where did it go? Okay, Dr. Bradbury.
Thanks. And sorry that I am always so talkative on these things, but I actually, so I tried to organize my thoughts so that it was less jumbled for Dr. Miller and all of the rest, because the last time I don't think I was as clear. So I wanted just to kind of go through a couple of things that I had been thinking about. So initially I was completely against telemedicine being a means of providing veterinary care for things that we hadn't seen the pet for all the reasons that Dr. Sullivan mentioned, and also I think partially due to my concern that clients, would have these expectations of us to make the time for this, and to Dr. Payton's point, that to me is one of my big concerns. Is I don't know that their family veterinarians. I know that as an internist, I have very little time to even see my patients, let alone then have time for telemedicine as well. So I think that the improvement in access to your veterinarian, I'm not sure that how that works, but I have heard some other examples, which I'll get into in a second. So in any case, my biggest concerns were that if, we're relying on telemedicine, we would be missing something when the clients would call with a problem. They are seeing it one way. We may not ask the perfect questions, and we might miss something really important and do a disservice to the patient and to the client by assuming we had all of the information, and without the exam, we might have missed something very important, like a irregular heartbeat or pale gums or something to that nature. So I think that's always been my concern. Anytime I talk to a client that's calling about a pet that I've seen, that's always my concern. It was my concern even overseeing interns who would call me on emergency for backup, and I would always go in and examine the patient too. So I understand that that concern, and that's why I've historically been opposed to changing this regulation. When Dr. Miller was talking about the concerns about, people outside of the state and providing telemedicine, that also was one of my big concerns, is these big companies coming in and trying to make a profit off of Californians without having any oversight. And the groups that spoke today were not asking for that. They were saying that we would have to have an in-person establishment of a VCPR, and I think that's a really good way to make sure that we don't end up in the international telemedicine situation that we talked about. And so that was where my questions were related to, is I was confused when the CVMA was talking, because what the other groups were proposing did require an establishment of an in-person VCPR. And then the other argument about the sight and smell and all of that, and obviously based on my previous comments, I feel like they are important, and I do think that the physical exam is very beneficial, but there are definitely patients that I have seen that I can't get my hands on anyway. The super aggressive dog, the fractious cat, that I'm actually anesthetizing before I can listen to their heart and everything, so that I can have an exam to potentially treat a very possibly something that is not, or not even a significant problem, but I'm putting that animal at risk by anesthetizing it without ever even, it's hard or anything like that. And so in some cases, we maybe are putting animals at more risk by requiring this in-person thing when we could potentially be observing the animal in the environment and, asking the client to do some things on camera to help us see like mucous membrane color and things like that. So those are just some of my initial thoughts. I did wonder why there is such a passionate following of telemedicine by these groups, and like, is this a financial thing for them? Are they trying to have banks of veterinarians or not? It doesn't sound like it, but it does sound like people are very passionate about it, and I'm not really sure why, but I don't know that I'll get an answer to that. I just think they care a lot about it. My views have changed a bit because I did listen to it was a 2-hour presentation or discussion at the AA VSB meeting, and while it was all pro telehealth, so there wasn't anything showing against it. There were the folks from Ontario were there and presented pretty compelling data for why this is it seems to be working for them, and how they really haven't had any issues with it, and that the veterinarians are using it in a very limited fashion because they're veterinarians and they're making rational judgments about their patients, and they're talking to clients, and there's a lot of preventative things that they're doing through telemedicine, which they couldn't do because they couldn't see anybody with COVID, and that is this COVID pandemic has limited the access to veterinary care because veterinarians are impacted, and there are it's weeks out sometimes for patients at this point in the general practices that I talk to. And then the other thing like they got me thinking about was we trust veterinarians to go in and do this physical exam, and that the physical exam is the end all be all, and we trust them to make determinations about recommendations based on that exam. Why are we not trusting them to make recommendations on a virtual exam? And it got me thinking about it, like, do I trust myself to make a good recommendation to a client who calls me, who, for example, I was treating for IMHA and now that patient has diarrhea? Do I trust myself to ask the appropriate questions? I know the client at that point. Do I feel like I can say, try a bland diet, give me a call in a couple days or tomorrow if they're not eating, if they're, give them some advice, versus, they've given me some answers where I'm like, I'm worried about dehydration. I really think you need to bring the animal in. And the answer is yes, I do trust myself to make that determination. And same with like what Dr. Sullivan was saying, he trusts himself to say, hey, I'm worried about that. I think you actually have to come in. Why? Like, we're all veterinarians, and so why aren't we trusting him? So those are just all of my thoughts on this, and I am a lot more open to working on this and trying to move forward, and not just being sort of like, no, we can't change anything. So those are my thoughts, and thank you for listening to my diatribe.
Thank you. Dr. Sullivan?
Well, I would go one step further. I think what we may need to do is to clarify the difference between telehealth and telemedicine. For many, many years, we would take our own emergency calls at night, and there was a judgment call there as to whether that animal needed to be seen or not. I wasn't making a diagnosis. I was using my knowledge and information to make a decision as what was best for this patient. And the idea that you're telling the client to try the bland diet, I don't think is making a diagnosis and making a treatment. I think that's general information that you can give a client, but to then to prescribe antibiotics I think to me, is crossing that line between general information to an animal who is acting, whether you see him or the client is describing it, is acting pretty normal and alert and not changing its temperament or mood or activity level to one of which now you're prescribing something. And to me, that's telemedicine. One is telehealth and the other is telemedicine. And I have been studying this for years, and including on the human side. And even on the human side, they have great difficulty in defining those two terms, and they do overlap. But maybe that's one of the focuses we need to do. But I think I have real concern about a health exam allowing a veterinarian to then, make a prescription or prescribe a drug based upon a health exam 3-4 months before. I don't think that is good medicine. Thank you.
Thank you. Ms. Riggs?
Yes, thank you. So I just wanted to try and address Bradbury's question about why we are so passionate about opening up access. And, for us, it really is access to veterinary care. That's a big goal of the ASPCA. We work very deeply in low-income communities in Los Angeles County and have experienced situations where we're going out into communities to establish VCPRs, but then there's a significant burden on those community members if there's a reoccurring condition or if there are additional symptoms to accessing veterinary care after that initial contact. And, certainly no one here doubts that low-income people love their animals as much as a higher income person that has a vehicle, doesn't have to use public transit, isn't on minimum wage, hourly wage, and can't miss work. And so this really opens up a lot of access. And I think beyond that, I mean, we recognize that there are folks with mobility issues. And I think why this is coming up right now is that I think the pandemic has really exposed in a new way how limitations on physical access to veterinary care can really be detrimental to both consumers and the animals. And these situations have been present, forever. And it's just now that we're really seeing how the general public is being impacted by this situation where there are limitations on the ability to get into a veterinary clinic. And so for us, it's about access to veterinary care and making sure that, for people that really do want to provide the care, but have, income restrictions, mobility restrictions, just any kind of limitation, that if they want to get that care, that we're trying to remove as many barriers as possible while understanding that, there needs to be some relationship with that animal. And we feel like, again, that this is a very reasonable a situation where the veterinarians can understand the animal and the owner of that animal, but still be able to break down those barriers to make sure that the animal is healthy.
Thank you. I have a question regarding the income barrier and access, because I got your information packet and I've read through it. And what access are they limited to? Because, I mean, this is something that is, and I really do want to actually find this information. We're trying to get all of the information that we can. And how are they limited, and how would telemedicine increase their access if it's an income base? I mean, if they're limited by income, how does telemedicine change that access?
Mm-hmm.
And also if with the mobility, if you're still requiring that they have established a VCPR, how does that change their access as well?
So I can speak to our experience in Los Angeles County. We're actively and deeply immersed in the communities of Baldwin Park and Downey, which are both very low income minority communities. And we have actively been going out with a mobile clinic to those communities to allow folks to access our veterinary services in the community and establish that VCPR. In many cases, there might need to be follow-up to that. And a lot of the folks in that community don't own a vehicle, so they may be reliant on mass transit. And most mass transit does not allow pets on, unless it's a service animal, onto the transit lines. Number two, many of these folks are working hourly wages. And so if they have to find transportation and travel to a veterinarian outside of their community, it might mean a half day off of work or even a full day off of work, which can be make or break for that particular member of the community. And so, if they are able to access, the veterinary care online from their home in the morning before they have to go to their job, or after they come home from their job in the evening, then naturally that means that they're not going to give up their wages or minimize the impact to their family income by being able to access that online. And so it's those types of circumstances. And then beyond that, certainly there are a lot of low mobility folks in these communities that, physically cannot get themselves to a veterinarian, even if one was present in the community. And quite frankly, in these communities, there aren't veterinarian offices in their communities. And so, that's part of the reason we're out there, is to ensure that the folks that want to get this care can, and it really is a geographical barrier for many of the community members as well. Does that help?
Yes, and I think because our one big concern that we look at as a consumer protection is that regardless of social status, mobility, income, you should deserve the same quality of care of standard regardless. That should never be something that we have to determine. It's a minimum standard that we have to look at, and they deserve the same quality of medical care. And we should never have to say you don't deserve anything different. You deserve the same standard of medicine as everyone else. So I think that is something very important to us, and we have to look at that as a committee as a whole and say everybody deserves the same, regardless of who you are, and make sure that access to care is the same minimum standard.
And I would just reiterate, we absolutely agree, and that's why we are so passionate about this. And right now, the barriers that exist in those communities does not allow for the same standard of care. The lack of veterinary services in those communities, the financial barriers, the transportation barriers, all of those things are serving to ensure that folks aren't getting any veterinary care, even if they want it. And so, absent, us being really immersed in those communities, probably, folks would not have any access whatsoever. And so we believe that, providing telemedicine to those community members doesn't compromise the level of care. We think it expands it, especially in conjunction with, us going out to the communities and trying to break down the barriers directly, that this is additive and really does bring up the standard of care to the level that other folks in higher income communities that have more access to veterinary care have in their communities right now.
Thank you. And I believe it's Ms. Kunzel. Did I say that? Did I butcher it? Did I?
No, you did. It's perfect. I answered to any variation of it, so it's a hard one. Thank you so much. Yeah, just to piggyback kind of on what Susan was saying, the San Francisco SPCA is right, right in line with how the ASPCA thinks about this. And I just also want to say that, we, in addition to kind of being on the receiving end of animals who are unable to access this care, we also operate 2 full-service veterinary hospitals, so we're deeply vested in this issue. We see well over 100,000 patients a year. We're 2 of the largest veterinary hospitals in the Bay Area, and we are seeing that it's not really just restricting access with respect to underserved individuals. Of course, we were instructed to limit this conversation to just the telemedicine component, but as Susan, alluded to, this is obviously a much larger picture that we're considering, and it's this access piece. And whether intentional or not, the current regulations restrict veterinary care in our state in several ways. This is just one component of it. And, I completely appreciate that we're trying to ensure that care is held to this minimal standard for everyone, as it should be. But practically speaking, we have a system in California where we have chronic veterinary disparities. We see this on the macro level statewide. We see this on micro levels. In San Francisco, we track this we know the neighborhoods in which the animals are being surrendered and there's preventable disease is not being managed. And these are areas where veterinary care is just simply unavailable or inaccessible to large numbers of. They don't benefit from a minimum standard of care because they receive no care. And so they're sort of, feeling these devastating impacts of systemic poverty, institutional discrimination, and again, this isn't just an issue that we see right now limited to these, disadvantaged communities. This is a problem that is only expected to grow over the next decade. And we forwarded this on to the V&B as part of our concerns. I trust that you guys have all seen it as well, but there was a very recent, very contemporary study conducted by Banfield that says that 75 million pets in the U.S., in addition to where we are right now, are going to lose their access to veterinary care by 2030 due to veterinary shortage alone. This is something that the industry is grappling with. We see this in our own hospitals in the San Francisco SPCA. And as Dr. Vogelsang alluded to earlier, we're still in the info gathering stage. The DCA waivers have not been in place very long. But at least preliminarily, we have seen at the San Francisco SPCA that there is a waiting list that is weeks long for patients to be seen. And so telemedicine is just one tool available to us to help us better connect with our patients, help us better triage, as our vets feel is appropriate, and manage their needs better. It certainly is not a moneymaker, I can assure you that. And we're here not only because we feel passionately about the issue for the future, but we also are here seeking kind of clarification for the broader industry. The truth is, one of the biggest impediments to telemedicine is confusion. Veterinarians are not going to use it if they are not clear on what is telehealth versus telemedicine, to Dr. Sullivan's point, and to the doctor that participated during public comments, I forget her name, but it just goes to show if we've been doing telemedicine by the phone all along, which I can tell you is exactly how my veterinarian operates, the way that we're operating today doesn't actually attract the way that that the regs are being interpreted. So this is a big issue. We really tried to limit our presentation, but we are deeply vested into this issue, not only because we care about the animals that are being surrendered without access to care, but we are operating hospitals, some of the largest in the industry. So thank you.
Thank you. Ms. Laredo?
Yeah, I just had a couple of comments. So I'm trying to look at this from a consumer perspective. And we know that when pet owners panic and they don't have access to veterinary advice, they consult Dr. Google. We can't do anything about that. I would rather that they have professional informed advice. And Nancy Ehrlich made the comment that we've been giving recommendations over the phone for years. We've all been in that situation. The practice closes at 5, somebody calls at 4:55. What should I do? And you have to make that decision. Do I tell them to come in the morning? Do I tell them to go get emergency care immediately? But I did hear a couple of comments that there have been 0 registered complaints. And I do want to point out that a lot of the clients who would seek out care over the internet might not be the type of client that would seek out veterinary care anyway. I used to work in shelter medicine for 13 years, and we had a low-cost spay and neuter mobile clinic that would normally have vouchers for free spays and neuters. And as the techs, we would beg the doctor, can you please look at this other condition on this dog, with this elderly client? And the vet was always hesitant because we knew as technicians and as the vet that this might be the only time that that pet would ever see a vet when they're getting this free spay and neuter. But the vet was concerned they couldn't do a full workup. They couldn't do blood work. I've been in situations where there were clients who didn't have a car and they had to take a taxi to take their cats to the vet. And I know right now during a pandemic, that's probably not feasible. So I still think we need to trust our veterinarians to use professional judgment. If they don't, that's a separate issue. We do still have our standards of practice. It sounds like it really is a regulatory issue. And I don't know that making this permanent would increase access. I stand adamant that we need these relaxed regulations during the pandemic, but I don't know that this needs to be permanent. And I also personally tend to err on the side of caution. And I've heard the push, California is going to be in last place. We need to be leaders. I don't think there's any benefit to rushing this just to not be in last place. I think we need to really think about the safety of our patients. And that's all I have.
Thank you. Anyone else? If you're done with comments, you can put your hand down unless you have another comment. Anyone else have any other comments? Silence. Okay. I know that this is not going to be the last of this. This will probably be on our agenda for a while. So we will continue this discussion, and I appreciate everybody being willing to participate in all of this discussion. I know I have taken a lot of notes, and I'm sure all of you have listened to all of this. I'm sure, I know I will go back and listen to all of the comments again when I go back and listen to the webcast again, because that's what I do. So, but I do appreciate this. This will be something that we continue to do, we continue to talk about, and we continue to engage all of the stakeholders in this. So this is not going to just be a one-time meeting and done. So yes.
Before we move on, Christy, I would just ask that we can open it up to the public comment one more time, since we've had a lot of discussion since the last time. So before we move on, just make sure we don't have any other people waiting to make comment.
Okay.
All right, this is a moderator, and at the committee's request, I have opened up the Q&A panel. So if you would like to make a comment, please type "I would like to make a comment" and submit it to all panelists. And we are displaying instructions for your reference. All right, this is the moderator. I see no requests for public comment at this time. Would you like me to close the Q&A feature?
Yes, please.
All right, it's been closed.
Okay, so let's move on to agenda item number 6. So we thank you all. We'll lose a lot of panelists now. Thank you all for attending. I appreciate you all being a part this morning. So let's move on to agenda item number 6, which is discussion and potential recommendation on proposed amendments to section 2035, article 4, division 20, which is duties of supervising veterinarian. I'm going to go ahead and turn this over to Jessica, and hopefully all of you have read this.
Yes. Moderator, would you mind sharing presenter role so I can share my screen real fast? Thank you. Let me see if I can get the right one. Okay. I hope you guys are now seeing the screen with the amendments, proposed amendments that were approved by the board in May of 2018. This is amendments to 2035. I provided quite a bit of background and how these came to be in the memo, but to make it a condensed version, the board, as part of their strategic plan in the 2012-2014 strategic plan, they wanted to research extended duties for RVTs, and they had punted this down to the MDC to do the research and to discuss potential amendments in 2035 to list some extended duties for RVTs to make it more clear on what they can and cannot do. They had quite a bit of discussion on what tasks would go on the list, and they ultimately decided not to make a list because it's just really it's impractical and difficult to specify all the tasks that they could do. And there's also concerns that if you omit a task, then the interpretation would be, well, it's not in this list, so they therefore can't do it. And they decided not to do the task. Instead, they decided to make it more up to the professional judgment of the licensee who would be delegating those tasks to know the appropriate task to delegate and base it upon the competency of that person that they're delegating to. So they ended up proposing recommendations to the board. The board made some minor amendments to that, and then the language that is before you is what was the result of that. When this rulemaking package went to agency, they raised a number of concerns as outlined in the memo that I provided. Basically, it's really, really broad, and it's overly broad to where it can create more issues than reduce the issues. It creates more confusion. And so they had asked for the board, if they want to proceed with this, to define all of these areas, define when it's necessary, define what extensive clinical skills is, define what requisite training is, define what demonstrated competency is. And so after reviewing this, we brought it back to the board to have them take a look at it. And they decided that we were going to give it back to the MDC to review it. During the board meeting, though, there were some concerns that were raised of whether or not this was even necessary at this point, because it appears that the amendments that were added in D are covered under Section A. So right now, if a licensee had delegated tasks to any other individual that they're not competent to do it, the board has ability to take action against that veterinarian under 2035A. So I have also discussed with our legal counsel, our deputy attorney general liaison as well, and we do not believe that D is even necessary. The public comment that we received during the board meeting was from Nancy Ehrlich from CARPTA, and so perhaps she can also chime in too. But I don't see the need for this, and I think rather than spend a lot of time trying to further define all of these areas, I think that the board should remove this rulemaking package from the queue and leave it as written. So with that, I'll turn it over to any questions that members may have and discussions.
Anyone? Don't go silent on me now.
Hello.
Yes, Dr. Sullivan.
Yeah, I think the reason that came up a few years ago and that we developed this was because we didn't think that A was specific enough to be enforceable. So if staff has no problems with the enforceability of A, then I don't think we do need D. At that time, we were told we needed to be more specific.
Yeah, and I understand that. That's why I wasn't ready for the board to make any determination at the board meeting. In the meantime, I did reach out to our Deputy Attorney General because I know that was a concern that was raised in the past related to enforcement. What she had opined is actually making it harder to enforce because there's no definitions of any of those. And so it could create more issues than solve any.
Okay.
Which is also what we talked about, Sullivan, if you remember. We had a hard time with these words and the verbiage of this as well, because we had the same concerns of how do you, we really struggled over the words because we couldn't come up with, well, what does this mean? How do you define it? Who determines it? And so when we talked about this at the MDC level, it was a struggle as well. And we just felt like we kept going down a rabbit hole.
So at this point, Christy, I don't know if no members have any questions or comments, we may want to open it up to public comment. If Nancy Ehrlich wants to give Cartha's opinion on this, or if any other public comment we have, and then the MDC can make a recommendation to the board.
Okay. So moderator, would you like to open it up, please?
Madam Chair, I will open it up. Okay, so the question and answer panel is now available. If you'd like to make a public comment, please type, I would like to make a comment, and submit it to all panelists. And we'll give you a moment to access that feature. All right, this is a moderator, and Nancy Ehrlich would like to make a comment. So Nancy, I'll let you know when you're unmuted. All right, Nancy, you're unmuted.
Okay, thank you. Well, I still have the same opinion I had last time, that this is unnecessary, that A answers the problem. And I think we've kind of gotten lost that the whole idea was to make a list of new job tasks that were reserved for RVTs. And since the committee decided not to do that, they felt they had to do something. And I think that this something is really nothing and doesn't add anything. So I would recommend that we withdraw the package. Thank you.
Thank you, Nancy.
All right, this is a moderator, and I see no other requests for public comment. Would you like me to close the Q&A panel?
Yes, please.
Okay, I'll do that.
Okay, do I have any recommendations from, sorry, my kitty is very uncooperative today. Any recommendations from the committee? Any motions?
Move that we drop item D on 2035.
Second.
I second.
I heard Dr. Sullivan, and I'm not sure I heard Dr. Lazarus, and then somebody else.
I have Dr. Lazarus as seconded.
Yeah.
Okay. So we will need to make it, now that we have a motion and a second, we have to open up to public comment again.
Well, do we have any discussion on the committee, any more discussion on the committee? And then you can open it up again.
Probably that motion I made was wrong. I probably should have moved, and I will correct the motion to move to remove the package from the queue.
And Dr. Lazarus, do you accept that amendment?
Yeah, I think that's the premise of what we're trying to do here.
Thank you.
This is Tara. I'm just going to clarify that it should be most likely a motion to withdraw the rulemaking.
So move.
Okay, and now Dr. Lazarus, you accept that.
I'm so sorry. I actually have to add on to that. It's actually not the MDC removing, it's making a recommendation to the board to remove the rulemaking package.
Oh my God.
It's fine.
Wow, this is getting complex.
All right, can we open it up to public comment, please?
Please.
All right, this is a moderator. I will go ahead and open the Q&A panel. All right, the question and answer panel is now available. If you would like to make a public comment, please type, I would like to make a comment in the field in the lower right-hand corner of your screen. If you're not seeing the field, please click on the question mark within a square at the bottom of your screen, and we'll give you a moment to access this feature. All right, this is a moderator. I see no requests for public comment at this time. Would you like me to close the Q&A feature?
Yes, please.
Okay, it's closed.
And we called for a vote on this.
Dr. Lazarus?
He gave up.
Yes.
Dr. Bradbury?
Yes.
Mr. Ekman?
Yes.
Ms. Laredo?
Yes.
Dr. Payton? I'm sorry, I didn't catch that. Dr. Payton?
Yes.
Oh, thank you. Ms. Schafelt?
Yes.
Dr. Sullivan?
Yes.
Dr. Warner?
Yes.
Ms. Pulowski?
Yes.
Motion carries. Thank you.
Okay, let's carry on, please. Let's move on to agenda item number 7, which is the discussion and potential recommendation regarding veterinary premises registration fees. Dr. Sullivan?
Okay, well, the memo says everything. I think the online or the survey, email survey was a great idea, but the execution was not equally great. So we're back to square one. We got less than 2% response. So the only other option that our subcommittee could come up with is to delegate to delegate a number of phone numbers and questions to each MDC board member to call themselves. It 200 if all of us share in that task. Unless somebody else can come up with a different idea, I think that's what we'll be left with to get this information in a timely fashion. We can put it off by doing it through hospital inspections, but that's going to take 3 or 4 years to get an adequate number. So I think we're going to have to take it on ourselves.
I do believe that Dr. Berry had some questions or some input on this that she shared. So I'll let her participate. Open it up to her.
Okay. Hi. Thank you guys for the work you've already done with the survey and everything. I think that I looked at the number of calls that each of us would have to make. If I am correct, you were talking about 230 or so calls. And if I estimate that at like 10 minutes a call, at least, because you have to leave messages and all of that, it's almost 40 hours, and that would have to be during the work week. And I personally currently wouldn't be able to do that. So I had some concerns with that, but I did have some other ideas. So there was a couple of ideas I had, but the first thing I thought we kind of, I don't know if, because I haven't been a part of these discussions, if we've already come up with sort of an idea of what we're trying to determine from these surveys, whether it's how many practices are 10 doctors and above versus 5 doctors versus solo or 2 doctor practices. And if we have an idea of what we at least initially thought we would be tiering the system as, then it might be helpful to kind of have at least a general idea of that. But in veterinary studies that are done, we often are unable to get the numbers that we would like in order to get a good feel of what a problem is or a result. In those studies, we often use some calculations, some statistical calculations to determine how many actual cases we need to have statistical power or significant numbers to make a determination that this is a representative sample of a population. And so I didn't know if we've done any of those calculations. I am terrible with statistics, frankly, but I do know that there is a way to sort of look at the number of hospitals that are in the state and then at least try and figure out really what the number is that we need in order to say that we have a representative slice. So that was one idea I had, just to make sure that we're not doing a lot of work that's unnecessary. But there's also a lot of information that's already out there. The AVMA does collects data on California that looks at it's the economics of things and looks at the number of doctors per practice. And they published that. And I looked at that, and they didn't have specific per state in their published study, but they did say, you know, like on average, there's 2 doctors per practice in the nation. But it seems like they've already kind of mined this data and have it state by state for other things. And I didn't know if anybody had any connections with the AVMA and whether or not we could reach out to them and just see, could we get that data? It might already actually be there. So that was one idea I had. The other idea I had was to first of all, figure out what the number is for, you know, what the number of clinics we really need to say that we have a representative slice of the clinics. And then with that, we could do a random sampling of, you know, we could number them 1 through 3,300, randomly sample that number, and then look at those clinics online and see what, how many doctors were at that practice. So I did that personally when I was starting this business, and sent out a bunch of postcards to each doctor at the practice. And so I actually have the data for most of the clinics in Central California, outside of a 25-mile radius from the Ethos Hospital. So I have the data for that. And it does have, you know, I'm able to determine the number of doctors per practice. It doesn't give me the number of RVTs, so that's missing. But, and I know that it's not completely accurate, because sometimes doctors have left or have come on board more doctors, but it gives you a pretty good idea. So that would be a much quicker way of trying to than trying to get a hold of premise, you know, the premise license holders. And we might be able to get the information rather quickly that way. And if the number instead of 230 was, you know, 20 per person, we could easily look that up and then kind of go from there. So those were just some of my ideas, but I don't know if you guys have already thought of those and done those, and I don't want to assume that you haven't. So anyway.
Thank you. Dr. Sullivan, do you want to respond?
No, we had not thought of that, especially I was not familiar with the AVMA data. We can definitely reach out to them. I'm not a statistician either, so I don't know anything about that arena. We would, you know, we were trying to get a large enough sample that we wouldn't have to seek out a statistician to refine it.
Well, and we have to be careful because we're
thinking if we had 200 each, and if we were getting a response from half of those, that would give us a 25% rate, would be, I think, significant. But again, I don't know. I mean, it would take time, without a question.
Yeah, and we don't want averages. That would be a big thing. We're not looking for an average number per hospital. So because we do want to tier the premises permit registration, that's what we're looking for. And so instead of doing, we don't want an average number of doctors per practice.
And it was real important to us also to pick up relief veterinarians and part-time employees to get them into a full, an equivalent of a full person, so that a practice that, you know, has 5 veterinarians and has 2 part-time and 3 relief veterinarians, that we get the total picture and not just who the you know, who is on the advertising or on the yellow pages or on the internet.
Right. Which is why looking online at their website is not really indicative of actually who's there, because they could be a traveling person that's there as needed, and then another person that's there 1 day a week and another person that's there 4 days a week. So we want to get a real indication of who's there. So go, Dr. Bradbury. I know you want to continue.
No, I just was like, I guess I think that that's a great aspiration to try and capture all of that data. I don't know when further down the line when we're registering people, if sometimes they use relief vets and sometimes they don't, if we're going to be really counting relief vets anyway. So I don't know if that's even going to be a way of being able to ask. It's kind of, but I totally understand the desire to do that. I don't know that we're going to be able to get 25% of the data. I don't know, Dr. Payton, I know you do a lot of papers. Maybe you know the quick equation to figure out what number we need, or if you have any ideas, since you do a lot of research. And I feel like some of those things can be applied here.
I think calling me out on the statistician stuff. No, I think, I do think having, I don't know, reading everything, I think it's going to be hard to get all the data accurately, because I think it's not a great motivation to say everyone that's there if you have a lot of people, especially if you're looking at increasing fees. So I think that's probably why, to some degree, the survey is not getting as good of a response. So I think at some point we may have to, I'm not a statistician, but I don't know the exact number that you would need, because it depends on the variables of what we're asking. But it may be worthwhile consulting with someone to see the number that we need, not to have a mean per se, but to have more of a general kind of idea of how many specifically we need to get the survey response from. But it's a big task. I think it's amazing how much you guys have. 2% is still 2%.
Any other ideas, suggestions, ways of getting there?
So do you guys think it's completely not worth the time to just look at the number of veterinarians that are per website? I do in between a 1 to 2 doctor or even 3 doctor practice and a 10 doctor practice, which is sort of what our goal, right, is to just try and figure out a general idea of the differences between clinics. And I think, again, at the AVMA, while they averaged it out in their economic study, they did collect specific data. And I think they may have, there's a 2 doctor practice versus, because when I took their survey, it asks, are you at a 1 to 3 doctor practice? And so they did stratify it. So they may actually have that information, which I think would be fantastic. That would make it really easy. But anyway, I just am wondering if you guys, because it's a very quick way of
CVMA may ask those questions too, I believe. And so, maybe with both of their information, at least asking, I know when you've completed, said they wouldn't share that information. So, however, but some information may be better than no information, and we're just trying at this point to see if financially, is it going to be worth it to create a tiered process and a tiered registration to make up some difference. So yeah, Dr. Sullivan.
Yeah, and this has to be defensible too. This is not something we can just arbitrarily pick out numbers. I'd like to hear Tara's comment on that. I think it has to be defensible.
Can we hear from Leah and then hear from Tara?
Yes, I was wondering, I know that we've seen all of the survey questions and all of that before, but if we were trying to personally reach out to hospitals, how many specific questions will we be trying to get the answer to? Or I know you've shared it in the past, but that was kind of my question or concern. What exactly do we want to ask these hospitals
It's
and that was
it's 4 questions. So yeah, there they are right there.
Thank you.
Tara?
So yeah, Dr. Sullivan's right. This needs to be defensible. We need to describe for the DCA review process as well as the Department of Finance and Office of Administrative Law why we might ultimately be raising fees. But there's the other stop is also the legislature. We've got to, describe to them why a tiered premises registration makes sense, how that's actually going to solve the problem that we're trying to get at, which is reducing RVT fees. So yeah, I mean, it's got to be defensible information.
I'm sorry, I'm missing my screen with the hand up. Yeah.
That's okay. You can, and then I know Dr. Payton has her hand up next too, so.
She could talk first, that's fine. I just.
Go ahead. Dr. Bradbury, go ahead.
Oh, okay. But are we just in the information gathering stage? I'm just new to this, so I'm just wondering, are we just in the information gathering stage to see if this is something we need to get specifics on, or are we trying to just get specifics right from the start? So I guess if we were in the information gathering stage, knowing a general idea of whether there's how many bigger hospitals there are, then deciding, do we need to get more specific because it is worth it? I guess that would be my logical way of going forward in terms of a stepwise thing, but I haven't been here in the other conversation, so I apologize if I missed that part.
No problem. This is the second time we've discussed it. I believe it's the second time. But we are trying to gather the information to be, like, as Dick says, to be defensible so that we can determine that this is why, if we develop a tiered system to lower the RVT, to lower RVT fees, that we're lower, or we can do this because we can raise this much money through the premises registrations. But we can't do that if we don't know the number of doctors per hospital, and we have to know the number of doctors per hospital to determine how much money we're going to raise. So we can't even determine what tier and how much money we could charge per tier if we don't know how many doctors. It's kind of the chicken or the egg. We have to determine how much money we can charge, but we don't know what tiers we can develop because we don't know how many doctors per hospital. So what we do know is that we have to raise $1 million to lower that's how much money to offset the RVT fees. We have said we probably will not be able to raise the full $1 million. But how much can we raise from this? And what levels of tiers can we create? So that's what we're looking at. And I don't, Dick, if you have something to add, if I didn't describe that very well.
Nope. Sounds exactly what the idea is and what we're trying to do. And it may not be doable because there are restrictions here as to it has to be legitimate and it has to have enough numbers to support it. And and our staff doesn't have the time or resources to do it themselves. So this was an attempt to figure out a way of doing it. So that's kind of where we're at, and it's kind of free thinking right here as to how to get that data that is defensible.
And
we can't.
Yeah, and we can't have outside volunteers help us do this because it can appear that they're benefiting from this. So we have to be very careful with why it's important that MDC is working on this. MDC has to be the ones that are working on this. So, Dr. Payton?
Yeah, so I have a couple of questions and then a thought about the defensibility. So one, so in this survey, these are the specific questions that are being sent. So it's kind of the fill in the blank that they're filling. Because one of the things that I have really learned with doing surveys is it's really, really helpful to have a social scientist give advice on how to make a survey easiest and to get the most defensible data from it. Because when people tend to fill in the blank, it tends to be so variable that you really have a hard time getting hard data from it. So a lot of times doing things like SurveyMonkey or Qualtrics, it's a lot easier for people to go in and do because they don't have to send anything back. They don't have to. And then also to have, instead of fill in the blank, have categories. And you guys probably went through all this, so I'm sorry if it's repeat, but oftentimes it's much easier to get concrete defensible data when you have those categories. And then, I think if we're looking at defensibility for something, again, one, looking at how the survey is created, and I know it's already done, but I've gone back many times because I've done a lot of surveys now, and I'm always learning how to make the data collection easier. And when you make it as in those categories, then a statistician can easily look at it and say, you need this many surveys because there's, you need an exact number for how you're going to make it defensible with this data. Like if there's so many practices in California, and I know you have a broad number, but it might be helpful. I do know some social scientist statisticians that may be helpful to give advice as far as what would be sort of like a shot in the dark, how many, we're hoping to get, because and we've said, you estimate you get less than half response regardless with a survey. So I don't know what you guys think about that, but I just think it may be something to look at to make you get a lot more concrete evidence and data and have it come back much more defensible in general.
So are you recommending, instead of fill in the blank, how many FTE veterinarians are employed or contracted, and then giving them a range, 1 to 5, 6 to 10?
Exactly. It's so much easier because right now, if you're trying to get data to defend the tier system, you're going to have like 5, 4, 3, you're going to have to make up those categories later track to create a database for. So if you have categories already, and I know it's a little hard because you're thinking, well, what are we going to make the tier look like? But you have to start somewhere, like you have a general idea of what that tier would be. And then
you're going to be likely to do it in 9 seconds and move on.
Oh, I'm sorry, I broke up.
Click a button, more likely to do it in 30 seconds and move on. Uh-oh.
Yeah, sorry. I think it's maybe my internet, but you're breaking up.
It's okay. Go ahead.
No, sorry. I don't know, when I look at a fill in the blank and then I think about creating a database with defensible data, it's really, really hard to do. It's much easier to have categories that they put that one, that one, that one. And then if you use a system like Qualtrics, it's confidential. I don't know how it works through our group, but Qualtrics, it does all the data for you sometimes easily. So and then you take that data and have like an hour with a statistician, and it's much more efficient. You will have all that data that then says, this is what we found. This is what we need, we can defend, and how we can say that we're going to increase our revenue by this much. And it may not be the million, but it'll at least give you a more definitive idea.
Thank you. Thank you. Tara?
So I think part of the conversation needs to be that we need to figure out ways to raise money quicker, because, you know, what we're talking about is RVTs today are having to pay increased registration fees. And so we need a quicker path on some level. You know, so the other possibility is we just go to the legislature and say, here's what we're trying to do. We would like, you know, 1 or 2 or 3 different tiers, and the premises and registrants themselves fight this or show up at the legislative level to say, oh, okay, you know, here's what we're willing to, you know, pay for this to offset the cost to RVTs. You know, there's got to be a balance between the premises registration increase and what the premises itself or management is willing to pay for the RVT registrations, or are they going to take that money away, what they were currently providing for the employed RVTs, and then, you know, make the RVTs pay it themselves? Are they going to pass the cost off onto the consumers? You know, I mean, we've got lots of different things to try and balance here, but the time frame is really important as well, because, you know, we can't just have the RVTs paying the higher fees for years while we're trying to figure out the best way to get data and then analyze it, because at the end of the day, this still has to go to the legislature. So it's, you know, I'm just encouraging you to, you know, consider other alternatives. If this data pathway goes nowhere, perhaps the recommendation to the board is to work with the legislature and committees to figure out the best tiered premises registration fee to offset the money that you're trying to raise to lower the RVT fees. So, you know, there's data, and then there's getting the job done. So, you know, maybe consider that in your deliberation.
Well, I like that idea. Point that it gets it out there in a timely fashion. And as Dr. Payton was talking, I just wrote down categories of 1 to 2, 3 to 5, 6 to 7 or more. And our particular area, I think practices will fall into those 4. I think in that size of categories kind of differentiates the capability, what the income is coming into that practice. And I think that the larger practices afford a larger amount. We're at full time, we're in practice. We definitely can afford a premises permit rate much better than a solo practitioner can. So to me, I like that idea of taking it directly to the legislature.
I just want to jump in. I'm sorry, because I'm sharing my screen, so I can't find my hand raised thing. I'm having a little bit of a panic attack here. But if you put it to the legislature, when we ask them to raise any fees, they need data or they won't touch it. I think saying, here, legislature, you figure it out. I'm really, really concerned with that idea, because even if they say, okay, we'll do the tiers 1 to 3, 4 to 5 or whatever, when they're going to need the data to back that up, or they won't put it in a bill. And then also, if we don't have any data, and then say best case scenario, it gets through, we have no idea if that's going to actually produce the funds that we need to raise. And we're talking about our sustainability as a board. And so I am like panicking with that idea, because even if the legislature says, yeah, we'll go ahead and put it through, we have no idea whether or not that's going to raise the funds.
So, okay, one, I would like Dr. Sullivan to read his tears again, but two, is it a possibility that we ask while we continue to gather data? Because I understand what Jessica's saying in that, yeah, we don't know. We have no idea, is that going to work? And so we're going to be like, oh yeah, let's just plan and hope for the best. In the meanwhile, there's not enough money. So we don't even know if it's going to work. So, but if we can, is there anything that prevents us from asking, but still trying to collect the data so that one, we can back up our ask, and two, find out, is this going to work? And three, when we find out what information we do gather, maybe it's not quite enough to cover the fees, so we don't go and do a reduction in fees and then go, oh yeah, by the way, we got to raise them again. So maybe it's like, okay, we can lower them a bit, but not all the way. I hope that makes sense.
Sure. Yeah, you can ask for it. I mean, boards ask to raise fees all the time, but they often require a lot of data to support to actually put something in print, because they don't want to create a chaos or a panic with people knowing that there's not a lot of data to support it. So I mean, yes, absolutely, we can go and we can ask to see if they'll be willing to put this in. But I find I would be very surprised if they put something in print without any data backing it up.
And the other problem is that this is a new concept. This is not what's in law right now. So we're asking them to change it without the data. I see what Jessica is saying. And I don't know, I can't imagine that we're going to get any different response from a survey where you just check off a category than what our first survey was sent out. I think the only way to improve the survey is by personal contact, and we've got limited resources there.
So I just have a quick question. So the first survey that you always, I mean, I've been reading about, but was it sent out a paper survey, or it was on the internet, or how was that first survey?
It was sent out through SurveyMonkey, and so it was all electronic, and it still is. We did, and it should explain in the memo too, but we sent it out to all the individuals, all the managing licensees that we had emails for tied to those premises registrations. So we initially sent it out to them a couple times, and we didn't get very great responses. So then we started sending it out in our monthly email updates to all of our stakeholders for all the emails that we had. And that still didn't give great results.
Yeah, I mean, I still think that, I don't know, it's much easier for people to do categories, because when we've done, so for example, we just finished a big survey internationally looking at burn wounds. And remember, a lot of this is based on someone's recollection, whoever is doing the survey. It's not always exact, but if you have a category that's written, they're much more likely versus actually writing a number. Saying that, I agree with Dr. Sullivan in that I think a personal follow-up is good. It's still hard for all of us to, I mean, in busy practices, it depends on who you're going to get in contact with. I mean, if you get the manager, it's just still hard to get the manager. So I wonder if you just modify the survey for categories and then follow up with the personal contact. But I do think you need some sort of data, even if it is the 2%. Like you have to have something to show that you have at least somewhat of a representative sample of what's out there.
Dr. Bradbury?
So I agree with Jamie about the categories. I looked at the survey and I wouldn't have had time to answer it myself when during the day, I would have opened that, and I can tell you, I looked at the questions and it seems pretty easy to calculate things, but you're asking somebody to look over a schedule and say, okay, well, if a relief veterinarian's here this much, they count for 0.5, and then I'm adding this, and so I think all of that, and then you just go, I'll do that later, or maybe I just won't do that. So I think I would have participated in a survey more likely if there was are there 1 to 5 versus, the categories that we're even talking about, and probably with some explanation. But I also agree that it's unlikely we're going to get a huge difference. We probably would get more of a response, but maybe not as much as we would feel comfortable, saying it's the accurate data. But I guess I'm still not sure, and I guess maybe I'm a little hung up on this, looking on the internet and looking at websites. I, again, have, I think over almost 300 veterinarians that are associated with the various practices. And, I have some practices that had 1 veterinarian and some practices that had 11 veterinarians. And that was just looking online sort of at the different clinics, and it would be preliminary data, but it would give us an idea of what we're looking at, which would then be able to extrapolate at least roughly what the revenue would be, and it would give us some data quickly. And so I think it's still a reasonable idea to look at that as a way of at least seeing if it's even worthwhile to pursue additional investigation as preliminary data. Sort of, is this worth doing the real study? So that would be my thoughts. But I don't know. I guess I'm not sure we are going to get to the defensible data very quickly. And I agree with Tara that we need to do something more quickly. So.
Thank you. I would like us to put out, if possible, another survey that lists Dick's tiers that he had mentioned. I think that we might see even an increase. Let's see, Jessica, would it hurt to try to do that? I guess would be my question, if we changed our survey a little bit and see if we could get some increase in the results. If we changed the survey to give some ranges and just say, if it changes the amount of time that it takes for somebody to answer a question. And then to Dr. Bradbury's comments on internet, the problem that I see with it is I personally look at people's internet or their websites, and you are a perfect example. They will put you down as a doctor in their hospital because you are a traveling person that comes to their hospital, and they count you as a doctor at their hospital, even though you are not physically there all the time. Just like traveling surgeons, just like traveling cardiologists, and they list them as their doctors. And so would it be a fair assessment if we look at their website and we see these doctors and we count them as doctors in their practices, because we don't know, because they're from Southern California, we have no idea who these people are, and we're counting them, but they're really not there, and they're not working there. And there may be, I have a doctor that is not a full-time doctor, so I don't want to, they should be counted. I'm not saying they shouldn't be counted, but we need to know. That's why the FTE part is pretty important. And we give that calculation, and that range will be easy to be able to answer because they can answer it. It's between this. It's a range. It gives it. And I think that that will make it easier for them to answer. Not saying not to count them. I'm just saying we can't, by looking at their website, have any idea how much a doctor works in their practice, if they're 1 day a week, if they're traveling, if they're relief, whatever, but they should still count.
To answer your question regarding the survey, we can definitely change the survey in any way that you guys would like. I think the category one will be easy to fix. However, I think to Dr. Bradbury's point about the definition and requiring them to do math and look at their schedule and figure it out, that still would remain because you guys have that definition. You're muted, so we see your mouth mute.
Why do I do that? I do that all the time. I mute so that you guys, it's just giving them that range so that they can choose it. It's quick, it's easy. It's a quick survey to answer. And I think, to Dr. Payton's point, I think it'll make it easier for them to answer. Sorry, Dr. Sullivan.
Just working through this out loud, which gets me into all kinds of trouble. What about if we are assigned different clinics like we are going to do this survey, but take Dr. Bradbury's example and look those clinics up online. And if there is a specialist that is listed in a clinic, and as long as we understand that we're doing it consistently with every clinic, develop information data that way, and even we can even put a range in there and make it a lot easier for us to do. But then have the MDC members do that. Do 200 online surveys of how many veterinarians are on that website. And that would be a quick response to give us an idea if we even should be going further. And if the data is pretty consistent, we could maybe even use that. I'm just throwing it out there. It would be us doing the work. We could do it in the evenings on our own, a lot quicker, and it would be a consistent database. And I don't care. Well, first of all, we're not tied to how many RVTs are there. What the primary premise was, how many individuals are there generating income for the practice, because that income will substantiate a higher premise permit if, in fact, it's a larger practice. So I kind of like that idea, but I'm just throwing it out there because I get in trouble when I do that.
Dr. Lazar, chef.
So yeah, I had a question. What is the total shortfall for the RVTs? I mean, how much money are we looking to raise? Has that figure ever been
$1 million? You froze. We lost you, Dr. Lazar, chef.
While we're waiting for him to come back on, I was just going to just respond to Dr. Sullivan's idea about giving you guys all of the information to look it up on the website. My concern is that we don't have that data either. We don't have necessarily even the name of their practices. We have an address. And so it would take some time for you guys to type in the address, try to figure out what practices is, and get that website, because we don't have that data available either.
So how do you go visit the practices?
With the address.
Yeah, well,
and there's not a link to a name.
So sometimes there are, but oftentimes what we found is that the name that's on the registration is not the actual name of the practice. Wow. And so it's something that we identified that's an issue, but it's going to take some time to change the design and briefs. So we don't have that information right now. It's actually caused recently when we were trying to do some research on the shelters in California. oftentimes they operate under different names than what's on the premises registration. So there's no way for us to even provide you that information.
Wow.
Well, see, Dr. Sullivan, you got us in trouble without it.
We would have a phone number, right? We have a phone number.
Yes, we have a phone number with 99% of them.
Okay, so we get a phone number, we call the number, get the name of the practice, go online. I mean, it's one extra step, but
it's only several thousand hangups, but I'm joking. Dr. Bradbury. I see all the hands, by the way. I'm getting
Well, so again, if it really is that we're trying to get preliminary data, I love the idea of maybe even having like our own checklist, like we would for a survey 1 to 3, whatever, as we go through the thing. What I did worked pretty quickly is I just went to MapQuest and did veterinarians, and then all of the veterinarians in that area would pop up, and I just kind of went through there, and I was looking for addresses and how many veterinarians are there and the veterinarians' names, and I am sure that it wasn't accurate in all cases, but it was pretty quick. You just click on those, and so I'm assuming that it's an assumption, but that most of those veterinarians in that area have a premise license. So we could do it by area instead if we didn't want to do it the other way. But I think it is a very quick step to call the number that's on file, as Dr. Sullivan suggested, and just get the name of the clinic. It's much easier than trying to get a hold of the manager and talk to them and all of that, and then just type in the name of the clinic. But also, if you type in an address, often it'll come up. So
I believe you can type in the phone number as well, and it'll come up. You can type in the phone number, and it'll usually bring up the name, or the website. So, if it's a business, so that's why I was joking. We can look it up that way. So, okay, Dr. Lazarsheff, do you want to try again? He's with us.
Oh, no, I got my answer. I thought you were joshing me about 1 million, but that's really the figure, I guess.
It's definitely the figure. Yes.
I don't think that we're necessarily saying that the RVT fees need to go back to where they were.
Right.
They need to go down some. So I'm not stuck on that 900 and some thousand figure, but we have to have something significant to offset that.
And that's what I was saying to Dr. Bradbury, is that the fees offset the $1 million or were raised $1 million, but it's a matter of how much can we raise with the tiered premises permit, and it doesn't have to come up with the full $1 million. It's just how much can we make up. So, Dr. Payton?
Yeah, so I was thinking, listening to everyone, so we're going to, with our goals being to quickly get preliminary data that you could then take to the legislature. Can we look at doing both then? So if we decide on those established ranges, right? So those established ranges, an internet search and the survey, you could do them both together, because then that shows that we're taking two different approaches to getting this data as quickly as possible. But I think we need to agree on what those ranges are. And then, with a range, you already have some degree of inherent error. So I think it might, with the internet search, I like that because, again, I do think it's easier than getting a hold of someone by calling them. I think the address and the number is pretty easy to look up, because we do that all the time with stuff. And so I think getting a preliminary, and even if they have extra doctors that they're not going to count as full FTEs, if you have that range, it'll help, recover some of that error. And again, it's just preliminary data, but at least it's something, and you can have it established, and then follow up with changing the survey at the same time and then sending those surveys out. So that way we have, I really like the idea of that two-prong approach, getting the preliminary information from the internet, using the established ranges that would be the same for the survey, sending out that survey and seeing what you get. So that way, if you don't get more response to the survey, have the internet information with that broad range of for potential doctor FTE. So I think that sounds, to me, I think that sounds like the best way to get that quick data that everyone's wanting to get. It would just be what we decide the ranges will be.
Thank you. Jessica, your hand is, she found her.
Yeah, I did. I stopped presenting. But I think that we can do that. If you are looking on the website though, and not relying on the survey itself has a premises registration number that they have to enter in. So if you guys are going and doing research online, just make sure that you are looking up what that premises registration number is, so we're not duplicating responses, because that would be my concern.
Yeah, I think I would rely on the survey more for your concrete data, but the internet search would be more like your backup. Does it correlate with what you're seeing in the survey? So that would be more for that aspect. But it'd be nice. It'd be interesting to see if they're the same too.
Well, what I was disappointed in on what information we got back, and I haven't seen all of it, but I saw the preliminary. We had a very high response from 1 and 2 doctors. We had very few that were over 4, and in our area, a lot of the practices are over 4. So I was frustrated with the spectrum of the response that we got. So that's why I think we need a different avenue and different numbers.
And Dr. Bradbury's, I know you're waiting, and I also wonder what avenue with the ones that have less, that when you have bigger practices, how much access do you have to the managers so that they're actually taking, they're getting those email surveys? Are they going to actually fill them out, because are they the ones that are having the access to that email? So I just wonder how much access they have to those emails. That's my question, but Dr. Bradbury?
No, Jamie said kind of what I was thinking, which was that it would, even though duplicating the results, or with Jessica's comment about the premise number and not duplicating the results, I actually think it would be very useful if we were duplicating the results so that we could show that it was reliable data or not, or know whether it's reliable data or not. So it might be interesting to have both.
Dr. Sullivan, can you share your tiers again with me, please?
Yes, there were. It was 1 and 2, 1 to 2, 3 to 5, 6 to 10, and 11 or more.
Thank you. I thought it was 11 or more, but I wanted to make sure. So, anybody else have any comments on this before? So basically what I have, just to summarize what we've done so far, is just to talk about, we're going to change our survey to the recommendations that Dr. Sullivan has made, to where we can just put it into the tiers. And then we will go on and we will create some type of way for our MDC committee members to do an internet search and look at the hospitals themselves And that's what we've discussed so far. And I know Dr. Payton has her hand up again, but I want to make sure that I've clarified what we've talked about so far, and that's what we have decided to do. Anybody else have any other comments before I go to Dr. Payton? Raise your hand. Okay, Dr. Payton.
Just one last comment. For that category, is there a reason why there's 4 when we're looking at a tiered approach? I mean, would it make more sense to ask if you have less than 5, 5 to 10, or 11 plus veterinarians if we're looking at creating a tier?
The only reason I had that 1 to 2 is I think there's a lot of solo practitioners out there that need as much relief as the RVTs do. So I think we need to capture that 1 to 2 person practice, which, economically, I doubt, from the data I see, they may not be as productive or as have as good a nets as what the larger practices do. I think if we go 5 or under, we're putting a fairly, I think there's quite a big variation in that category of practices.
No, I completely agree from that sense, but I'm looking at it more towards, are you then not would they not apply then for that premise increase? I'm trying to figure out how that would fit when you would create that value or that increase in charge. Would they, because that would be a 4 prong, someone who doesn't get increased and then a certain amount of increase per that number. So I'm figure out if we look at using that data for changing cost, would you then say if you're a solo practitioner, you wouldn't get that increase? Is that what we're saying?
There may not, it's going to come down to how many are in each category as to how we then apply raises or cost increases or not. You can make it 2 categories. What I'm saying is I think that we need to capture this very small practices separate from the other groups. And as I look at our community here, I think a 4-tier system represents what I see out there much better than a 2-tier system or even a 3-tier system. I think the practice that has 4 or 5 practitioners, it has an economic advantage by volume over a 1-person practice. I think that 8, 9-person practice has an economic advantage over a 3-person practice. So I'm just arbitrarily picking those numbers. What we end up with is I really don't care. It's the principle of doing it. I'm just looking at our community and how different practices break down.
Yeah, no, that totally makes sense. I just wanted to clarify that. Perfect, thanks.
I think there is a question that we need to ask, though, Christy, and that is if we proceed with this for 2 things. One is I think the subcommittee needs to do some research itself. In other words, you and I need to get 10 premises permits at random and see how this would work out and see how efficient it would be. And then I think the other question is, if it does prove out to be efficient and doable, I think the question needs to then be asked is, would all of the MDC members be able to do this on a time, be willing and able to do this?
Okay. Any other questions? Okay. So I'm going to open this to public comment.
All right, this is the moderator. I will go ahead and open the Q&A panel. The question and answer panel is now available. If you would like to make a comment, please type, "I would like to make a comment," and submit it to all panelists. We are displaying instructions for your reference. This is the moderator, and we have a couple of comment requests. The first is Nancy Ehrlich. So Nancy, I will let you know when you're unmuted. All right, Nancy, you've been unmuted.
Okay, thank you. I'm a little bit confused because you keep talking about how you need data to present to the legislature, but we already have the data on how many licensed veterinarians there are in California and how many licensed premises there are. We know there are approximately 12,000 veterinarians and approximately 4,000 premises. And what I had suggested previously was that you divide $1 million by the number of veterinarians, and then you know how much you have to raise the fee in order to generate $1 million. It seems to me you're complicating this whole process a little bit too much. I think it would be helpful to find out, to do a small survey to find out typically the average number of veterinarians so that you can work at the tiers. But beyond that, I don't think having these statistics on the actual number of veterinarians should be sufficient to prove that you can raise the amount of money that you need. That's my statement. Thank you. Sorry.
Thank you, Nancy. All right. The next comment is from the California Veterinary Medical Association. So I'll let you know when you've been unmuted. And you are unmuted.
Hi, this is Valerie. I want to say first that we definitely do support trying to lower the fees for RVTs, but I have some questions about this process. First, do we know for sure, is it defensible to make the assumption that the number of full-time employees automatically means it's a more profitable practice and could afford the higher fees? I know that there are solo practitioners who don't do well. I also know that there are solo practitioners who do very well. So could you actually make that assumption legally to say that we're going to charge this practice less or more than another practice? Also, how would you track the annual movement of full-time employees? How do you know for sure that a practice is not going to hire more or have to reduce the full-time employees? And would that cost increase the expenses for the Veterinary Medical Board to track those numbers every year? Because my assumption is if you're going to base fees based on this potential information, that it's going to have to be incredibly accurate, or you're going to get some pushback from practices who are paying higher fees and you don't have their accurate number of full-time employees. Lastly, do you know how the corporate practices would deal with these questions? I'm not sure if they can always speak for the corporation and answer these types of questions. They may be able to on an individual basis, but I know sometimes when we've gone to them, they just send us to corporate. So those are my questions. Thank you.
Thank you. All right, this is a moderator, and that is the end of requests for public comment. Would you like me to close the Q&A option?
Yes, please. Thank you.
You're welcome. It's closed.
Any more questions? So, Dr. Sullivan, I see your hand.
Well, I agree with your concern about the the number of veterinarians in the practice and how that can change. To make this enforceable, and I think Tara had some concern about this, I think that we would have to include that question on the renewal of the premises permit every year as to the number of veterinarians. I think it does have to be documented on an annual or biannual basis. And I also agree there's some solo practitioners that are very efficient and do very, very well. But in general, and I, again, I'm getting in trouble by saying generalities. I think that a practice that is a large corporate practice or a large private practice does have a lot more efficiencies than a small practice. I think that's pretty well documented. But it's a method of dividing the cost of these fee increases without dumping it all onto the individual doctor's license fee.
Jessica?
Yeah, and to the concern of being able to maintain that information when doctors come and go, there is a way in Breeze to add modifiers onto the license. And what would happen is if we add a modifier based on the tiers, they get a different modifier per tier, and then you would drive the fees based on that. And so on a renewal, what you could do is say what category they currently fall under, and then they would have to do, and that fee would be charged, but they would have to attest that it hasn't changed. And then if it has changed, it creates, if they have to change the rate, the tier, then we'd have to figure out if that's a possibility to change it at the time of renewal. It might end up having to hold the renewal to change the modifier based on the change. So that's all things that we would have to work out to see even if that's something that we could do.
Thank you. Dr. Bradbury?
I had the same concern as Val when I was looking at this and thinking about it with the number of doctors. And I agree with Dr. Sullivan that in general, bigger practices have that, but there are going to be like spay and neuter clinics and things like that low cost clinics that perhaps it wouldn't be reflective of. And another thought I had was based on sort of taxable income, but I don't know that we would ever be able to ask for that information. But that also seemed like a reasonable way to not collect data, because that's going to be impossible, but to decide on who should be paying more, who can afford more than $400 per premise permit. But anyway, I had those same concerns.
Anyone else have any other comments? Suggestions? Okay, so we have our work cut out for us. Continue. And it looks like at this point, we have to take a break for lunch. And so, Jessica, do we need to do can we do 30 or do we have to take a full hour?
That's up to the committee.
Committee, what would you like to do?
30, let's get it over with.
So we will take a 30-minute lunch and return at 12:45. Can we do that, everybody? Okay, 12:45 it is.
Okay.
Thank you. To eat. Or did you stay there, Dick? You're on mute.
I'm at home, so I got something to eat.
Well, Jessica, our power went out at the hospital. And whenever the power goes out at the hospital and before the generator kicks on, the calls all go to my cell phone. And so during the meeting, I'm like, Ken, you need to answer my call. That was fun. That was really fun. So. What, buddy? Okay. Stop. Stop.
Hi, Christy. This is the moderator. Just letting you know that I'm here whenever you want to get the meeting started again.
Don't know if we're all back.
This is the moderator. Yes, it's hard to know. You might want to do a roll call.
Christy, you could ask everybody to activate their cameras just so we can see them so they know that they're back.
Anybody who's on, please activate your cameras so that we know that you're all back. That way I can see you. There we go.
This meeting is being recorded.
Okay. So we can move on to agenda item number 8, which is discussion and potential recommendation regarding foreign educated or experienced applicants for veterinary technician registration, which is Leah and Dr. Payton. So I will go ahead and turn it over to you.
Okay, I guess I can start, and of course have Dr. Payton and Jessica and anyone else comment as we go along. Really, this was given to our subcommittee, as you guys know, kind of the background's in here, but we brought up at the July Mdc meeting and as well as the Vet Med Board meeting, looking for a possible route for foreign educated technicians to become RVTs in California. So we've had one kind of preliminary meeting at which everything's kind of gone over in the memo here that hopefully everyone's had a chance to look at, but we were kind of trying to figure out if there was some way we could find a pathway for foreign graduates using current regulations and or, you know, possibility of making a checklist for board staff to be able to individually look at candidates, and most of them, a stumbling block seem to be regulations do have written in there supervision of a California licensed veterinarian or having graduated from a program in the United States or Canada in the language there somewhere. So we're kind of looking at reaching out to the AVMA as well, because we've heard that the AVMA has done some work on this topic, potentially also reaching out to other state boards to find out if other states happen to have pathways for foreign graduates. The other prong, I guess, that we're looking at as well is to try to find out how many potential applicants this pathway is necessary for, because certainly we know we need more RVTs, and if there are people out there, that we're limiting access to, we want to be able to figure that out. So we had discussion with Nancy Ehrlich was with us in our first subcommittee meeting, and I believe she has 2 possible people over time that have reached out to her regarding this. And we were wondering for CDMA as well, and anybody else, if you guys have any input as far as the number of people it may impact, and kind of any suggestions, moving forward for this. We're kind of just at a starting point, I guess I would say.
Dr. Payton, do you have anything else to add?
Yeah, no, I would just echo Leah's points. I mean, I think we are definitely glad this was brought to our attention, because I do think that there are just a couple of people that are interested right now, but I think this could be a bigger issue, and we definitely need more RVTs that are skilled and have that background. So unfortunately, right now we're just in the more information gathering phase, and definitely would love any input as well as we start, investigating this more and figuring out what recommendations we would make further.
Thank you. Any comments from the committee? Don't see any hands raised.
Ms. Laredo has her hand raised.
Oh, I looked too because it said it was like red. Oh, there it is. I got it. I apologize. Go ahead, Ms. Laredo.
So I just wanted to add, I am actually on the AAVSB subcommittee for PAVE for RVTs, and we are also still in the information gathering stage, so we can potentially share our information. We have a meeting next week. So we haven't made a lot of progress, but we are working on it.
Fantastic.
Anybody else? Not missing any hands this time. Usually Dr. Bradbury's like this, so. The real hand. Okay, so let's move on. Hold on.
Sorry, can we go on to public comment, please?
Oh, I'm sorry.
It's okay.
I apologize because I'm getting client calls right now and they're distracting me, and I apologize. And a cat that's like right here. Yeah, so public comment. Can we open it up to public comment, please?
Sure. This is the moderator, and I have opened up the Q&A panel. So if anyone would like to make a comment, please type "I would like to make a comment" in the field provided in the right-hand corner of your screen and submit it to all panelists. We are providing instructions for your reference. All right, this is a moderator, and we have a few individuals that have expressed a desire to make a comment. The first is Nancy Erlock. So Nancy, you've been unmuted.
Okay, thank you very much. I just want to point out, I don't know if Sophia Cardoso is on the list to make a comment. She is in the audience. She is the British RVT that I had been speaking about. And so she has some information. So I'm not sure who's able to check in because she joined the meeting after it started. So I want to make sure that she's able to make a comment. Because one of the things that she told me was that there were quite a few what they call veterinary nurses in Britain who do want to come to the United States, but they've looked into the process and it's so complicated that they just forget about it because it's not possible. So I think we'll find that if we make this process more doable, we will find people that want to come here. And oddly enough, Carpter just got an email today from an Indian RVT who wants to come to California. Says, hello, I'm Hardev Singh. I've done my diploma in veterinary science and animal health technology, veterinary technician in Punjab, India. I want to work in California. Please tell me the process. So I think it was quite ironic that I got that this morning. Really, I would hope that you would be able to speak to Sophia, because I think she can make the case quite eloquently.
This is the moderator. Thank you, Nancy. And our next request for public comment is from Sophia Cardoza. She is with us. So Sophia, you've been unmuted, Sophia.
Can everyone hear me?
Yes.
Yes. Hi. So I'm as Nancy said, I'm a veterinary nurse here in England. I am registered here. I graduated. It took me 4 years. I graduated at a university here in London. It was a degree, a veterinary nursing degree, a bachelor's degree in science. And so this first came about last year as an opportunity for my husband to move to California through work. And for me, I started speaking to some of my colleagues about it, and lots of nurses had said they'd looked into it. And they just said, there's no point. They don't recognize us. You'd have to do it all over again. They were saying, look into Canada. It's much easier. Obviously, the standards of veterinary there are great, are amazing. So the opportunity to go and work there is obviously appealing to lots of veterinary nurses here. And our standards are good, but you guys are still, slightly ahead, I guess. And so, yeah, it was frustrating to to see that there's just no pathway. And so you talk to the AVMA, they just say, go speak to the individual state. And yeah, you just kind of hit a wall. So it would be great to try and find a way, even if it's on an individual basis. I'm not sure. I have a colleague of mine, a former colleague of mine, she took her 3 years to become registered there as an RVT. She'd already moved there. She had to go through Wisconsin. They did kind of a combination of her qualifications and her experience here in the UK. And then she, in the meantime, kind of started working there, not as an RVT, obviously, just until she got registered. But it took her a very long time. And she said, you know, and it's not for the faint-hearted. It took her, she had to email some 30 states and call lots of people. And it was a hard process. But, we are, lots of us are more than qualified. We are extremely skilled here. And I've worked with, US vets that have come over here, and they've said, it makes no sense because we are more than skilled and qualified to work there, and if there's a shortage, I don't see why not. Yeah, that's about it.
Thank you, Sophia. And that is the end of our request for public comments. Would you like me to close the Q&A panel?
Yes, please. Thank you.
You're welcome. It's been closed.
Thank you very much for commenting and sharing. We do appreciate the information. Any other comments from the committee? Okay. So I appreciate you guys continuing to work on this, and I think it's apparent that we have a lot of gathering of information, and it's nice to hear that AAVSB is also getting information on this, and it'll be nice to share that information and work together so that we can move forward. So I appreciate that. Okay, so moving on to agenda item number 9. Thank you for putting it up there because my cat has decided he wants to sit right on my binder. So update from the complaint process audit subcommittee, Dr. Lazarchef and Dr. Warner.
Yes. Can everybody hear me?
Yep.
Okay. So this we were giving several cases to go over, and interesting, this time we were given the timeline.
Do you want to let Dr. Warner go over it? Because we're barely hearing you now.
Process entailed, or start to closing. We were asked to evaluate. Let's let her do it then.
Just in time to let you hear that, right? Dr. Warner, do you want to give it a try?
Sure, I'll try to pick up where Kevin left off. So I am new to the subcommittee, but we do have a new process, and we were given a very nice summary of how long it is taking in each step of the process, as well as a very nice survey monkey that we can fill out for each one of the cases. So I think that the goal is to be more consistent about our feedback. And in the survey, we're asked as reviewers to look at the standard of care. Well, it's all in the memo, so I don't guess I need to read through it for you guys again. But so that we can be more consistent with the feedback for the subject matter experts. Also, it was very enlightening for me to see how long these were taking and where the greatest amount of time was being taken. And so that is one of the things that we were looking at as we went through each one of these things. Where was the bottleneck? So.
It looks like, Dr. Warner, you were muted at the last part of that.
I'm not sure which part we missed out on, but the big thing I think for me was looking at where the bottlenecks were and how long this was taking. As I said, I'm new to this, and so to realize that I was looking at cases that were from 2017, 2018, and some of those cases had taken over a year in the subject matter experts' hands, and most all of them took a year plus up to 2 years at the Attorney General's level. So, like I said, I'm new. It's very eye-opening to me. Another concern, I guess, that I had that I talked to Jessica a bit about is that I felt like there were several of the cases that we reviewed this time that really did not warrant maybe subject matter expert time and expense that the board would have to incur. So those are things that we could put in the SurveyMonkey feedback. So I think that's it, the improvement in the process seems to be very significant.
I would agree with all of that. Anything we could do to shorten the time when we have to have a subject matter expert or shorten the time at the DOJ would be immensely helpful to this process because it's just taken too long in almost all of these.
I know at our last meeting, I believe that Jessica had mentioned too that part of this process was to identify some of the areas where there was like some of the expenses that we could have reduced because of the investigations. And I think that was part of the things that you were looking at. And so I'm curious to find the improvements in those areas, and has the new process been able to help you identify some of those things as well?
Yeah, and actually, the subcommittee, we haven't been able to get them that data on the cost specific to each step yet. We're working on compiling that data to provide them for their next review. The new change to this process, the goal was really to give the subcommittee a clear picture on not only the subject matter expert report itself, but to look at every step of the way what happened to this case. And I think assigning the cost to each step too would help identify where, not only why it's taking so long, but the amount of money that we're spending on this case. Because a lot of people don't even realize that if we have a long case that's 3 weeks in a hearing, which we have quite a few of those, that is actually would never be covered under cost recovery. So the longer a hearing goes, the more expensive it is. So that's important in that the subcommittee can look at how many experts were on this case, how many staff were involved in the case. For example, if you have a case where you have 4 subject matter experts, say you have 2 subject matter experts and 2 inspectors, and then you have, say, 5 people, staff touching that case, what we're seeing is the normal process then was for the Attorney General's office to subpoena all of those individuals. Well, the more individuals you have, the longer the hearings go, the more the DAG has to prepare different individuals for testifying, and the cost just continues to grow. And so I think that's a really important factor for this committee to be evaluating, and we hope to have that information to them during the next round of case review.
And we also talked about that the cost goes up for the respondent as well. It's not just, it costs the board money, but it costs the respondent money as well. And so looking at all of these factors, I think is extremely important. And you'd shared some of those expenses last time at the last meeting, and that was just, some individual costs. It wasn't even all of, like you said, at every step. And I think that it would be interesting to see how much money we can potentially save if we became more efficient. So.
Yeah, I would agree. Anything we could do to streamline this process. I know, Jessica, you talked about having, before it's even to the DAG, to have a statement in there what the board would settle for. Have you instituted that, and has that given you any feedback on whether that's shortening the process or not?
Yeah, so there's quite a few changes that we've already implemented. I think we talked about several times. Number one, we only have one subject matter expert on a case. There are rare exceptions where we may have to send it to a specialist on top of the subject matter expert, but we try our best to have one person serve as that expert. We also have reduced the amount of cases that we send to DEVI, Division of Investigations. I think I mentioned before, they're roughly $250 an hour, where we pay our inspectors $250 per inspection. So if we are able to use our existing tools with our inspections team more, that will also save money as well. We are sending, when we do decide to transmit to the AG's office, we send, if we're willing to settle, we send stipulated settlements to the AG's office at the time of transmittal. That cuts down on a lot of the time that's spent. Oftentimes, what was happening in the past is that if the staff will send over the case over to the Attorney General's office, and then the Attorney General's office, it takes quite a bit of time for them to assign it to someone, and then they were going to set the hearing date a couple years out. And then it wasn't until right before the hearing that they were having mandatory settlement conferences. And that whole time could have been eliminated had we had started the negotiations right up at front. And so we have been doing that now. As far as showing the data of how well it's working, I think that's going to be a little challenging for at least for the next couple years, because the cases that we're working on right now are the older cases. So we have cases from 2016, 2017. I think we have a handful from 2015. So these cases are really complex, which I think is why in the past staff it was challenging to address them. It was easier to go to the less complex, easier cases to do. So these cases that are, if we do decide to transmit them to the AG's office, we'll still implement the changes that we have, but we can't fix what was already done to this case. So I think it's going to take a while for us to start seeing the results, but I think just knowing the cost for each step, I think it's safe to assume we're going to save quite a bit in all costs.
Any other comments, suggestions? Thank you, Dr. Warner and Dr. Lazarsheff, for continuing on with this committee. I think that's definitely helpful. I think it's going to be interesting to see how much improvements can be made. So, okay. Well,
can we go to public comment first before going to the next one?
Thanks. I'm going to just, you know what, if I can I'm going to get that down. I'll be okay. So public comments. I'm more worried about getting my cat off this.
This is the moderator. Thank you, Madam Chair. I've opened up the Q&A panel for public comment. So if you would like to make public comment, please type "I would like to make a comment" in the field in the lower right-hand corner of your screen and submit it to all panelists. We are displaying instructions for your reference. This is the moderator. I see no requests for public comment at this time. Do you like me to close the Q&A panel?
Yes, please. Thank you.
You're welcome. It's closed.
Okay, now. Now we can go on to future agenda items, priorities, meeting dates.
So members, I provided you an email back on September 28th with the MDC meeting dates. So they are January 27th, April 21st, July 21st, and October 20th.
any questions or concerns on those dates? Okay. As far as any future agenda items, I believe we're going to be continuing on a lot of the items that we've already started on. I don't think much has changed. So I think we'll continue on those. Yes, Dr. Bradbury.
I saw on the previous, I think it was on the notes, the meeting notes, that there was some, I think for a future meeting item was the number of clinics per premise license holder. Is that something that where there's like, in some cases, you know, tens of clinics, maybe even up to 100 clinics at one, or maybe it's not the premise license holder, it's the MDLs, but, and I didn't know if, is that something that you guys were working on or planning on working on?
It's on our list of items that we, so we put together a list of items and we put it kind of at the bottom. It has been something that the MDC has discussed before. It's been on our agenda before, and it wasn't too long ago, but it was something that was brought up. So it's still on there. But when we kind of figured that we have enough on our agenda right now, it won't drop off. And so it will be something that remains on our to-do list. But then so basically what will happen is when one thing drops off, then we'll move that up on the priorities list. So that's kind of how things work. Yep, we have, I think I will go back to my notes and read. Yeah, there were several things that were brought up, and there are a couple other things that basically were brought up, and they basically will wait until other things drop off. It's kind of how they work. So, any other questions? Priorities? And I will not forget to open this up to the public this time. So we can open this one up.
All right, this is the moderator. Thank you, Madam Chair. I have opened up the Q&A panel. So if anyone would like to make a comment, please type, "I would like to make a comment," using the field in the lower right-hand corner of your screen. Submit it to all panelists, and we are displaying instructions for your reference. This is the moderator. I see no requests for public comment. Would you like me to close the Q&A panel?
Yes, please.
All right, it's closed.
Thank you. And that is it. Anybody? Adjourn? Thank you all.
Thanks, Christy.
See you guys in a couple months.
See you guys.
Good one.
Thank you.
Thank you.
Bye.